All are mute except you and me.
Yes, we are live. Very good evening from Ortho TV. Welcome to Ortho TV online education webinars. We would like to thank all our faculty for sharing their knowledge and expertise with all, especially in such challenging times. We wish all our audience a healthy and safe days ahead, and we hope these webinars add value to your time. These webinars are dependent on internet speed, which might be at times unstable. Please bear with us for any issues with internet. Today we are having Delhi Orthopedic Association's MIDCON Part 1, Fragility Factors. Now, I request Manish Sir to start the webinar.
Yeah, thank you, Shamshul. Sorry. Let me share my screen. Can you see my screen? Can everyone see my screen?
Put it on slide mode, sir. Play.
Yeah.
Yes.
Yeah, good evening, everyone. And I welcome you all for this Delhi Orthopedic Association MIDCON 2020. Today's theme is fragility fractures. Now, this conference, MIDCON, is usually held every year for 2 full days. And but Delhi Orthopedic Association is privileged to be one of the first states in India, all the state chapters, to have a full conference on a webinar. And thanks to Corona crisis, and it will be done in 2 parts. Today is the first part, and the second part will be on Sunday, 19th. We will have a small inauguration ceremony, and let me introduce you to all the dignitaries. I am Dr. Manish Dhawan. I am treasurer of IOA and this webinar moderator. Now, Professor R.C. Meena is our chief guest, and Professor Meena is president of Indian Orthopedic Association, and we are very privileged to have him. He is the chief guest, and he is professor and head of department at SMS Medical College, Jaipur. He has more than 40 international and national publications to his credit, and more than 100 international and national podium presentation at the podium. He has delivered many orations, chaired many sessions, and he has been a national guest at various international conferences. And he has organized many state CMEs and national conferences. And Dr. Meena is very, very renowned teacher, and almost around 300 students have received their MS under him. I welcome you, Professor Meena. Welcome.
Thank you, sir.
Dr. Atul Srivasa is our dynamic secretary of Indian Orthopedic Association, and he is the guest of honor. And he is past president of UP Orthopedic Association, and he is a former chairman of International Liaison Committee of IOA, and former chairman of CSRC IOA. And he has delivered many guest lectures, more than 200, chaired many sessions, and he has been awarded A.K. Gupta Trophy, which is a very, very prestigious trophy of IOA for successively for 3 years, 2013 to 2015. I welcome you, Dr. Atul Srivasa. Dr. B. Shivshankar, he is president-elect of Indian Orthopedic Association, and he has done his graduation from Hubli and post-graduation from Solapur, and he's practicing in Solapur. And he has done many innovations. He is an innovator, and some of them are Solapur technique of interlocking Solapur sleeve, Solapur broken nail extractor, and Dr. Shivshankar's name is synonymous with interlocking nail, and he has conducted over 700 workshops on interlock nailing. He is the founder member of Nails, and he has written many book chapters, and he is active Rotarian and has done a lot of charitable work. I welcome you, Dr. Shivshankar.
Thank you very much, Manish.
Yeah. Professor Rajesh Malhotra is a jewel of Delhi, and he is immediate past president of Indian Orthopedic Association. He is chief of AIMS and Jayaprakash Narayan Trauma Center. And past president of Delhi Orthopedic Association. He has done many numerous national and international publications. He has more than 450 publications to his credit, and delivered many lectures at various platforms, and he has authored many books. Now he is actively involved in ICMR WHO task force for osteoporosis. So basically today's topic is fragility fracture. So that is one of the domain of Professor Malhotra. So I welcome him. He will be joining late because he is traveling. So he will be joining us shortly. Dr. Sharad Agarwal is our president of Delhi Orthopedic Association, and he's senior consultant orthopedics and joint replacement surgeon at Max Super Speciality Hospital, Padapalganj. He is past president of East Delhi Orthopedic Association, and he has presented many academic papers at various national and international conferences, delivered many guest lectures. And I welcome you, sir. Dr. Sharad, I welcome you.
Thank you, Dr. Manish. Thank you.
Dr. Hitesh Lal is very dynamic secretary of Delhi Orthopedic Association, and he is professor at Sports Injury Center, Safdarjung Hospital, and Vardhan Mahavir Medical College. And also, he is formerly professor at Central Institute of Orthopedics at Safdarjung Hospital. He has written more than 100 national and international papers and delivered many guest lectures. I welcome you, Dr. Hitesh Lal.
Sir, thank you.
Dr. Vijay Sharma is webinar convener, and this is his show. He has arranged the whole faculty. He is a very dynamic young person from Delhi, and he is professor of orthopedics at Jayaprakash Narayan Trauma Center, AIMS. And he's the joint secretary of Delhi Orthopedic Association. He's faculty for AO. He has done his fellowship from Germany, and special interest is pelvis acetabular surgery, complex orthopedic trauma management, and he has many publications to his credit. Welcome, Dr. Vijay Sharma.
Thank you, sir. Thanks a lot. Thank you.
I introduce our young dynamic Dr. Ravi Chauhan. He's associated with me, and he is basically the backbone of this webinar. And he is a pediatric orthopedic surgeon at Gangaram Hospital. Welcome, Dr. Ravi.
Thank you, sir.
Dr. Ashok Shah, we thank you for your support for this webinar. He's the main guy for this webinar, and he's editor of Ortho TV, and he's assistant professor at Sancheti Institute of Orthopedics and Rehabilitation, Pune. I welcome you, sir. Dr. Neeraj Bijlani is consultant orthopedic surgeon and tech enthusiast at Ortho TV, and he's also one of the backbone of Ortho TV. Welcome, Dr. Neeraj. Dr. Shamshul Hida is a dynamic person. He's coordinator of Ortho TV, and he's consultant orthopedic surgeon at Patna. He's the joint secretary of Bihar Orthopedic Association and Assam, India. And he's editor of Ortho World. I welcome you, Dr. Shamshul.
Thank you, sir.
Okay. So now I request our president, our Indian Orthopedic Association president, to address this August gathering. Dr. Meena, please.
Thank you, Manish. And the cabinet of the Delhi Orthopedic Association giving me this opportunity. Respected President Dr. Sharad, Dynamic Secretary Dr. Hitesh, our past President of IOA, Dr. Rajesh Malhotra, President-elect of IOA, Dr. Shiv Shankar, my senior and friend Vikas Gupta, sir, and dignitaries on the screen and off the screen, various members connected with today's MIDCON of the Delhi Association, faculties from the country and abroad. Friend, it gives me immense pleasure to welcome you all for the Delhi Orthopedic Association MIDCON event, which is the most vibrant state chapter of our IOA. The Delhi Orthopedic Association as a state chapter is a robust academic organization and have contributed immensely in the field of academics and organizations. The visionary and scenario brought up and built this state at the level of height from scratch, and its heartened to see this association in its vibrant position as on today, as a robust. Even as president, I can proudly say that Delhi Association midterm meeting has all the ingredients of a glittering academics meet and a high-end scientific get-together. Fragility, fracture is another topic, pertinent topic, and really very interested, useful topic for nowadays. And deliberation will help greenhorn and senior practitioners playing their trade alike friend time here are desperate, and we are dealing with an unprecedented and crisis and unforeseen challenge in form of COVID-19 pandemic. I was never prepared for this kind of pandemic, such a huge crisis in beginning of my presidential tenure. I can confidently share with my views that we generated a fund of rupees 15 lakh with no time from the sponsor. Among them, one was a Caleb and another omnicourse like that, and distributed the face mask and shield across the country and its length from east to west, south to north. And under the stalwartship of our Manish Dhawan, this was achieved in very difficult situations with the help of the military vehicles in the JK area, and the many of persons who receive it, they really appreciate this humanitarian act of the IOA cause at my behest. Hello?
Yes, sir, we can hear you.
In the end of this, I would welcome all the delegates and faculty and congratulate organizers, President, Secretary of the Delhi Orthopedic Association, and Teslal for putting together a web meeting in such a crisis and difficult situation where the physical gathering and physical journey is not possible. With this meeting and platform, I request those who are listening me, please come to the 19th July Indian Orthopedic Association virtual meeting of our executive committee meeting, so that we can proceed ahead and bring the IOA at its own speed. Thank you very much giving me this opportunity. Jai Delhi Orthopedic Association, Jai Hind, Jai IOA. Right.
Thank you, Professor Meena, for these kind words and showering blessings on us. I really thank you. And I now request our Dynamic Secretary of Indian Orthopedic Association, Dr. Atul Srivasa, to speak few words.
Good evening all. President, Indian Orthopedic Association, Professor R.C. Meena, sir. President-elect, Dr. Shiv Shankar. President, Delhi Orthopedic Association, Dr. Sharad Agrawal. Honorary Secretary, Dr. Hitesh Lal. Our web coordinate moderator, and our treasurer, IOA, my dear friend, Dr. Manish Dhawan. The web convener, Dr. Vijay Sharma, and dear friends. Well, it is a pleasure as well as a privilege to be attending this unique virtual MIDCON of the Delhi Orthopedic Association. Let me inform you that this is the 5th DOA MIDCON that I am attending in succession, and each one has been a very enriching experience. Nowadays, virtual conferences have become the need of the hour because of this COVID crisis, and I really congratulate the organizing team for putting this act together. The theme for today's symposium is Fragility Fractures, which is very pertinent in today's era with super aging population worldwide. Our past president, Dr. Rajesh Malhotra, has special interest in this field, and I'm sure he will give us eye-opening insights on this topic. We have a wonderful faculty, and I'm sure at the end of the day, we'll go back home much wiser and richer in knowledge. Thank you for inviting me, Delhi Orthopedic Association. I'm a proud member of the DOA. Long live DOA, long live IOA, short live Corona, stay safe, Jai Hind. Thank you.
Thank you, Dr. Atul, for such kind words. I request Dr. Shiv Shankar, our President-elect, to address this gathering. Dr. Shiv Shankar.
Good evening, everybody. President IOA Dr. Meena sir, Secretary Dr. Atul Srivasa ji, Delhi Orthopedic Association President Dr. Sharad Agarwal ji, DOA Secretary Dr. Hitesh Lal ji, Dr. Manish Dhawan, Dr. Ravi Chavan, Dr. Nalit Maini, Dr. Prakash Kotwal, Dr. Vijay Sharma, Dr. Rajesh Malhotra, so many other members on the panel here today, and my dear members of the Delhi Orthopedic Association and all the online viewers of this first virtual meeting of the Delhi Orthopedic Association in the form of midterm annual meet. Heartiest congratulations for having arranged such a wonderful workshop. This is the third time I'm attending the meet of Delhi Orthopedic Association. Two earlier one in person and this one today in virtual meeting. Friends, Corona se ladna hai, darna nahi hai. There is always something positive, even in this pandemic, which has caused such a havoc to the mankind. First and foremost, all of us have become computer savvy and also acquainted with these Zoom meetings, and we are all sharing the knowledge, which is pouring so much, especially with the availability of Ortho TV and the recorded versions available. Each meeting is breaking all the earlier records, and sometimes we have 10 to 15,000 viewers watching some of our programs. This is really a good thing which is happening. Even the earlier IOA PG meets, which had just a few hundred people watching live, now we have got 5,000 to 6,000 people watching all our IOA PG activities, thanks to the lead taken by Dr. Manish Dhawan. I know it's the effort which has been done by the Delhi Orthopedic Association under the able presidentship of Dr. Sharad Agarwal ji, and also Dr. Ravi Chavan, the conveners, who are the brain behind it, and that is the reason why it is so popular. And Delhi has conducted so many webinars already for the PGs, and they have taken now the lead to continue with the Indian Orthopedic Association PG Pathshala also. Congratulations for that, and I thank you very much for that. This pandemic has also exposed a lot of lacunae in our health system, and we are glad that some of the Indian players are coming in manufacturing PPE kits, masks, respirators, etc. That is a good sign for us, because whatever we are procuring from outside India, which are costing a huge exchange to the country as well as onto our pocket, in due course of time, we all will be getting them at such a low rate. A good quality one will be available. So it's definitely a positive thing we should consider the Corona has taught us. And also this Corona has made a lot of changes in the government also. Government is appointing doctors. Now they know that they were very ill prepared earlier. That's why when we had only one lab which was testing the coronavirus when the pandemic arrived in India in March, but now we have got more than 650 labs across country. So it definitely it has helped to upgrade our medical system. So we should take this in along with our stride. And probably I'm not sure these webinars today I attended earlier in the morning, Rajasthan Orthopedic Association meeting. Now I'm attending the virtual webinar of Delhi Orthopedic meeting. So I'm sure that this is the mode of our future communication till Corona ends. We don't know when this Corona ends, so we should be prepared to plan even a bigger conference. Even probably IOCON we might go after 1 or 2 years. Probably I am not sure when the Corona will make that havoc even for IOA activity. With these few words, I welcome all of you for this today's webinar on behalf of Indian Orthopedic Association, and I congratulate Delhi Orthopedic Association for having arranged this wonderful webinar on a fragility fracture, which is the bread and butter of a general orthopedic surgeon who treats hip fractures every day. Thank you very much, and all the best for today's function.
Thank you, Dr. Shiv Shankar. And now I call upon Dr. Sharad Agarwal, who has done this show. Dr. Sharad Agarwal is our president of Delhi Orthopedic Association. Dr. Sharad, please address the
Thank you,
August
Dr.
gathering.
Manish. Chief guest of the evening, Dr. R.C. Meena, President, Indian Orthopedic Association. Guest of honor, Dr. Atul Srivasa, Secretary, Indian Orthopedic Association. Other dignitaries from IOA, Dr. Shiv Shankar, President-elect IOA, Dr. Rajesh Malhotra, past President IOA and Organizing Chairman of MIDCON 2020. Dr. Manish Dhawan, Treasurer and IOA and Conference Moderator. The eminent international and national faculty of MIDCON 2020, Executive Committee and all members of Daily Orthopedic Association, delegates and friends. On behalf of Daily Orthopedic Association, I welcome you all to MIDCON 2020, which is the mid-year conference of Daily Orthopedic Association. To fit in the present day scenario, the virtual conference has been divided into two segments, the first of which shall be held today. Conventionally, the DOA MIDCON is dedicated to the subject of trauma. This year, the theme is Fragility Fractures, a subject which is very relevant to the present day health concerns. Roughly half of all women and up to 1/4 of all men suffer a fragility fracture in their lifetime. Especially in elderly patients, fragility fractures can lead to increased risk of mental and physical problems and a significant decrease in mobility and quality of life. Hence, quick and effective remedial measures are necessary in these cases. However, such preventive and therapeutic measures come with their unique challenges. To deliberate on these subjects, Dr. Vijay Sharma, the conference convener, has invited a galaxy of noted international and national speakers. The topics to be discussed are exciting and pertinent to the everyday clinical practice. All in all, it shall be a great learning for all of us, and I'm sure we shall be a lot wiser about the subject after the conference. In the end, my sincere thanks to Dr. Meena, Dr. Srivasa, and Dr. Shiv Shankar for kind words for DOA. Thank you.
Thank you, Dr. Sharad, for such a nice show which we are doing it today. It is all your doing. And now I request our Dynamic Secretary of Delhi Orthopedic Association, Dr. Hitesh Lal, to address us.
Thank you, Dr. Manish. I, on behalf of Delhi Orthopedic Association, am grateful to all the IOA members, Dr. Professor R.C. Meena, President IOA, Dr. Atul Srivastava, Secretary IOA, Professor B. Shiv Shankar, who is the President-elect, and I'm thankful to Dr. Rajesh Malhotra for hosting this Daily Orthopedic Association MIDCON. And DOA has hosted this year's 27 webinars, of which 17 have been PG webinars, and the attendance has been 5,800 plus. So that is the interest, that is the theme of the IOA president, that is excellence in perfection and PG orthopedic education, an achievable goal, which the DOA is following. And these PGs have attended from all over the subcontinent, and these courses have been attended very well. And the theme of this conference is very pertinent to this time. If you look at the epidemiology of the COVID pandemic, the only thing about this is the fragility fractures incidence has not decreased. And it's very apt that we know about how to deal with fragility fractures, as we can make a difference to the life of the patient if we treat them well. I hope for a great academic interaction between the delegates and the wonderful faculty that we have, national and international. Thank you very much.
Thank you, Dr. Hitesh. And now I take opportunity to welcome our foreign faculty, Dr. Kapil Kumar, Dr. Amit Sharma, and Dr. Inder Gill from United Kingdom. And for our Indian faculty, Dr. Malhotra will be joining us, Dr. Kotwal, Dr. Vikas Gupta, Dr. Tahir Ansari, and Dr. Shiv Shankar. He is also faculty. Now I hand over to Dr. Vijay Sharma to introduce the faculty. Dr. Vijay, please introduce the faculty.
Hey, thank you, Dr. Manish. Good evening, respected seniors and dear friends. On behalf of DOA, it's a great pleasure for me to introduce our distinguished international and national faculty. For this MIDCON, a very warm and hearty welcome to all the speakers. I will start with the international speakers. We have three eminent faculty members, all of them they are from England. So Dr. Kapil Kumar is consultant orthopedic surgeon in Woodend Hospital and Aberdeen Royal Infirmary, Aberdeen, UK, and special interest is shoulder surgery. And he's going to talk on replacement, and a very, very interesting lecture, I think, for all of us. Dr. Amit Sharma, he is working as a specialist in a busy hospital in the heart of UK, that is Lieutenant Dunstable Hospital. Special interests are arthroplasty and minimal invasive surgery. Dr. Inder Gill, I think he is a pelvic acetabulum chap, and every year he is one of the star faculty for acetabulum courses. So he is consultant orthopedic surgeon in Salford Hospital and University of Manchester, which is a teaching hospital in Manchester. Special interests are lower limb arthroplasty, revisions, and pelvic and acetabular trauma. Now coming on to our eminent national faculty, and start with the teacher of teachers, Professor P.P. Kotwal, my teacher. He's chairman, Institute of Orthopedics and Joint Replacement, PSRI, New Delhi, and he was former professor and head of the Department of Orthopedics at AIIMS, New Delhi, former chairman, hand section IOA, former AO trustee, past president of ISSH, and more than 500 guest lectures, 3 books, more than 120 publications, and 8 orations to his credit. Welcome, sir. Dr. Malhotra, sir, he is Chief Trauma Center and Professor and Head of the Department of Orthopedics, immediate past President IUA, past President DOA, and special interest in fragility fractures. And maybe he will be joining us a bit late today. Dr. Shiv Shankar, sir, V. Shiv Shankar, sir, President-elect IUA, consultant at Iyengar Orthopedic Center, Sholapur. He has conducted more than 700 workshops on interlocking nails. Past President Nails, have many chapters on interlocking nails. Even I have seen his lot of YouTube videos, national and international books to his credit. Active Rotarian with a lot of charitable work. Welcome, sir. Welcome to the MIDCON. Dr. Vikas Gupta, sir. He is presently Director and Head Division of Hand to Shoulder Surgery, Max Hospitals. Area of interest is upper extremity, hand and upper extremity surgery. He is the past Secretary, Indian Society of Surgery of Hand from 2012 to 2015. Welcome, Dr. Vikas. And Dr. Mohammad Tahir Ansari, he is presently working as additional professor in AIIMS. Again, upper extremity, interest is upper extremity, hand and upper extremity. And he did his fellowship from Spain, and he did his AO trauma fellowship from Tübingen, Germany. So welcome, Dr. Tahir. So this was regarding the introduction of faculty, and now we'll start with the academic session. So since Dr. Malhotra is getting late, so we'll start with Dr. Vikas Gupta's lecture. He will be speaking on osteosynthesis and fragility fracture of proximal humerus, tips and tricks. So Dr. Vikas is there? Dr. Vikas, you are not audible.
Okay, actually my screen was, I think. Can you hear me now?
Sir, please
Yes,
put it
sir,
on
yes.
slide mode, sir.
Can you hear me now?
Now you're audible, sir.
Yeah,
Yes, sir.
sorry. Proximal humeral fracture in elderly, they are the fragility fracture wise, they are fourth commonest, commonest being spine, hip, wrist, and then we see shoulder fractures. I'll start with something which should have been a last slide, like in Cochrane database and other studies showed that when you compare non-surgical treatment with the surgical treatment is not resulting in better outcomes. We'll discuss that whenever there's a discussion, because this will be a long discussion. But what is special about elderly patients? They have comorbid conditions, they have osteoporosis, healing is delayed, and rehabilitation is poor because of there could be a pre-existing rotator cuff injuries or poor muscle mass. This was a Prophet trial in which again non-surgical versus surgical treatment was compared. But here we are talking about there were 10 cases of complications during the hospital stay because of the comorbid conditions. Mortality in this group was 9 in surgical, 5 in conservative. So old age people, there could be some amount of natural causes of death. But again, conclusion was no significant difference between surgical treatment and non-surgical treatment. Whenever we talk about proximal humerus fractures, Neves classification, we do talk about it, but I'll not go through it because it's commonly dealt with. Idea being it's 2-part when there are 2 fractures, 3-part when 3 fragments are there, fragments being greater tuberosity, lesser tuberosity, head and shaft. The better classification nowadays we are using was by the Hurtle. It is based on Codman and Ligo classification. It's like 4 parts are there. one being head, the second being lesser tuberosity, other being greater tuberosity and shaft. Here, the important thing is predictors of AVN were discussed. If calcar length is less than 8 millimeter or disruption of posterior medial hinge is there, or complex fragments, complex fractures, something like when there's an anatomical head, or these are the 9, 10, and 11. If these are the fracture patterns, then chances of AVN are high. But that doesn't mean that it's a contraindication for ORIF. It just predicts that chances of AVN are high. So when we read our orthopedics, general basic teaching is if there's a fracture near the joint, there should be a stable fixation for early mobilization to achieve better function. And fractures which are unfixable, they should be replaced. So same guidelines are followed here, but unique fact here is that tuberosity, though they don't add stability to the fracture configuration, but they are the major contributor of functional recovery. So you have to reconstruct rotator cuff and tuberosities to get the better function. Again, osteoporosis. In osteoporosis, we have to treat fracture as well as osteoporosis. So your contrary to this, we have to treat the patient, not the fracture. So we have to treat the fracture. Why we have to treat the fracture? Because it was seen that proximal humeral fracture had a 5 times higher risk of hip fractures in subsequent years, a subsequent first year. So if we see a fracture humerus in an elderly patient, we have to fix fracture as well as treat them for osteoporosis to prevent the second fracture. Again, this is a review article coming from in 2007, which was say for displaced fracture, open reduction, locking plate synthesis represent a good operative procedure in displaced 3-part and 4-part fractures. We'll start with the cases. This was a case 19 years ago. At that time, locking plates were not available. So fracture fragments were displaced. Joint was dislocated. We could reduce it on table. Very happy that everything is good. But for multiple screws were used. So we were crossing our fingers whether fracture will unite or implant will fail. But we were lucky enough, though there was some amount of backout from the screw, but we could get the good function. This was a function of patient, but we cannot make it generalized. This was again, in that era, 81-year-old lady had a low ejection fraction, interstitial lung disease, so high risk case. So what we tried to do, percutaneous fixation, one incision here, one incision there, try to fix it with multiple wire and screws. But 2 months later, everything fell apart. This was not the only case, cases like this. So things, whatever we were doing, like things were not, and fragility in osteoporosis, implants were not holding. So there were options of injecting a cement into it before fixation. But this is a very old video. Everyone must have seen it. But again, to talk about it, there was this side is a non-locking construct, simple plate. This side is a locking construct. So as we say, whenever we fix a fracture, there's a rate between fracture healing and implant failure. The locking plates, they last longer, so that they give more time for the fracture to unite, but they are not like 100%, but these are the options we had once locking plate came into the play. But definitely locking plates, they can also have a varus collapse resulting in failure. So they're not 100%. So what are the things which can prevent the varus failure? Things are like screws should have a purchase in subchondral bone, so that if there's a short screws, the hole will not be there. So chances of failure are high. There should be a medial calcar support. This side, there should be a support here. Medial side should be well supported. Otherwise, varus failure chances are high. So the tips and tricks to prevent failure are like you should have anatomical reduction if there's no combination. Medial displacement of shaft can be done to achieve some amount of stability in the for the head. calcar fixed angle screws, 1 or 2, they increase the stability of the construct. Many times strut graft, fibular strut graft, that acts as a stability for the fracture. Medial interosseous plate, though I have not much experience, tried once, but not very satisfied. That can be used to give the stability. And if there is a combination or gap medially, we should do a bone graft there. So this is about the medial interosseous plate. Difficult because you have to reflect the lesser tuberosity, put the plate inside the neck and supporting as a hinge in the head. This is advocated. Or if there's a gap medially, you do a bone graft, or there is an angle fixed calcar screw. Different implants, they have 1 or 2 calcar screws which prevent the varus collapse, giving a good purchase in this direction. Or what happens many times, we fix the head, and when we are putting a compression screw, what happens, the shaft goes laterally. So when shaft goes laterally, the head is unsupported. So we have to have a whenever we do the reduction, the medial support should be there. We have to make sure that our cortical screws are not pulling the shaft towards the plate. So if there is a amount of gap between the plate and the screw, we have to accept that. Otherwise, if head is unsupported, it goes in varus failure. As we had talked, the strut graft, many times it helps in preventing the failure or collapse. So this was one of the article from 2007, importance of medial support in locking plates about proximal inguinal fracture. They said the medial support should be good to prevent the varus collapse. Regarding how we do it, most commonly we do it through the deltopectoral approach, but transdeltoid approach is also described. It is personal choice. I prefer deltopectoral approach because that can many times give a very extensive approach. Things to remember that we have to identify biceps because it's the only landmark sometimes when it's a 4-part fracture. If fracture is going distally, we can erase anterior 1/3 of the deltoid for the plate should sit properly on the shaft. Here we must understand it is not getting a fixation of the fracture. We had to take care of tuberosities, rotator cuff attachments, and disengage the fragment. This is how you disengage the fragment, disengage the head from the lateral side, and get the temporary reduction. So when you pull on from the sutures on the lateral aspect, it prevents the varus of the head, and you do the temporary fixation. Once we have done the temporary fixation, we can pass our threads to the plate, which we have to tie it later once fixation is done. So this is how you have to put your threads before, otherwise many times it becomes difficult once fixation is done to pass your threads through the plate. So once you have put your threads to the plate, fixation, temporary fixation is done, then we go for the permanent fixation or final fixation. So these are just the steps: getting our tuberosities, temporary fixation, and getting a full fixation. So this is one of the cases which shows like fixation with the. We're coming back to the old previous case, fracture like this. So if you see, these are the fragments, tuberosities, and once we have done the fixation, the calcar screw, they give the good amount of support here. Screws which are in different direction in the head, they give better purchase in the head, and locking shaft screws, they prevent the collapse, axial collapse of the metaphysis in the fixation. There are many implants available. We are just discussing 2 of them. Pillows is, it can be used, it was not site specific, or the periarticular plate, which is site specific. Advantage is it is little bit lower, so the impingement chances are lower. One of the screws goes very posteriorly to catch hold of the greater tuberosity, and plate sits little bit anterior. So in periarticular plate, it comes very anterior, so you don't have to erase much of deltoid if your plate is longer. but it is site specific. So it is different for left and right. The implants are different. Again, 64-year-old male had a fall, had a comminuted fracture. So CT scan was done to see tuberosity is different, head is separate, shaft is separate. So as we were discussing, you get a first, you decide what should be the height of the plate. Then temporarily you fix that plate with the wire so that your height of the plate remains constant. Then you get the reduction. As we were talking, if you try to bring shaft towards the plate, there is a lateral displacement of the shaft. Whether there are two things you can do: either you get your shaft medially, or you support your head so that you can get a good. This is, we are using the thumb to support the head. So once you support the head, you can get an accurate medial reduction. This is very important. Once you get a good medial reduction, then you can fix with the help of wires, temporary fixation with the wires. And when you're satisfied, you can go for a final fixation. Here you have to use you pass on your threads to the plate beforehand, because once you put your plate with plate and screws, it's difficult to pass your threads. I won't go into details. So this is how, once you've got your fixation done, your sutures should be tight so that your rotator cuff and tuberosities are secured. But if you see gap like this, then you have to do your bone graft, because you cannot leave a gap medially. Either we can use a bone substitute or bone graft medially so that it doesn't collapse. But suppose many times what happens, we just miss that putting threads, because sometimes it is very complicated. So different implants, they have an undercut. So to pass the sutures, so you can pass sutures like this. Otherwise, you can pass sutures in the shaft of the plate. This is how you can pass sutures in the shaft of the plate. Or you can use your diamond, the passer through the your anchor to pass the thread into the plate afterwards. It's a very simple thing. So many times we find it difficult once you fix to pass our screws, but it is very important. So whenever you're talking about fragility fractures, osteoporosis, the study was done, what is the impact? Like in first 3 months, there are some cases there was impaction and loss of reduction, and it was significantly correlated with the age, female patients, and amount of osteoporosis and metaphyseal combination. We won't go into the detail to how to calculate osteoporosis in humeral fractures. It's a topic by itself. Other implants which are available, one of them is a multi-lock plate. It's again, it's very good for two-part and segmental fractures, but comminuted fractures and where tuberosities are really displaced, you have to do the open reduction. So it is sometimes become very tedious to get 3-part and 4-part through the multi-lock, but definitely very good implant for the 2-part and segmental fractures. There's some contraindication. You cannot always fix the proximal humeral fractures, 4-part fractures, aged 65 or 70 plus. You should try, you should think of other things. If there's a head splitting fracture or impression fracture, the humerus, 3-part fracture is severely osteoporotic. These fractures, you should, if we have other things available, the replacement, then you should think of replacement, because these fractures result of fixations are not good. So take home message would be that you can improve purchase by having screws up to the subchondral bone. Medial support calca screws, they prevent the varus collapse. Locking screws, they ensure that angular stability, so it prevents the collapse and loss of reduction. Again, we have to use screws in the shaft, locking screws, because it helps in preventing subsidence in a metaphyseal area. Function after fixation always depends on reconstruction of rotator cuff and tuberosities. So it is not your final X-ray how it is seen, how you have fixed your tuberosities. It is important to get the functions. And one must remember that all fractures may not be reconstructible. So you have to have other options. For that, I say, by this, So Dr. Kapil will talk about fractures which are difficult to fix. So over to Dr. Vijay. Thank you.
Thank you, Dr. Vikas, for an excellent presentation. So regarding fixation tips and tricks in a geriatric age group. So any questions from the faculty or from the panel?
Can I ask question, Dr. Vijay?
Yes, sir.
Dr. Vikas, excellent lecture. When you started, you said there's so many studies which say the treatment for operative and non-operative treatment is almost same. So are we practicing it now? I mean, and
see,
where do you
okay, this study, okay, I think Kapil also will agree. Kapil, would you like to join in for this PROFA trial? See,
yeah, thanks, Vikas. I think we have to remember that whatever the headlines of PROFA trial conclusions are, you have to dig a bit deeper. So if you look at the PROFA trial, the headline says there is no difference in non-operative or operative treatment. But then when you look at the study design, a number of patients where the surgeon definitely felt that you needed to operate. So fracture dislocations, massively displaced four-part fractures, or where you were convinced that surgery needed to be done, they were excluded from the study group. So the study group included what the authors called as surgical equipoise, where you're not sure whether I should fix it, whether I should leave it. So that is the group. So if you're not sure, then probably don't operate. That is the message. But if you've got somebody with a fracture dislocation, somebody with a fracture dislocation with a displaced great tuberosity, which if you know that if you don't fix, the patient will get a cuff deficient shoulder. So that group of patients you must fix. But where you're not sure, and it's the osteoporotic old person, three-part fracture, which is a bit tilted in varus or valgus, tuberosities are massively displaced, those you could leave non-operatively and probably your outcome will be similar. But again, it was a pragmatic trial. It did not look at specialists doing the operations, but we have to be mindful of the fact, considering, I don't know, the audience includes people of all experience. If you're not sure whether you can fix the fracture well, then probably let nature do its job and let nature take the blame rather than you taking the blame. That's my take on it.
So there was a big bias in case selection, plus a follow-up of study, follow-up, all the patients were on a telephonic interview. They were not called for the proper follow-up and proper examination. So scoring was more of a subjective, I would say, but there are definitely a lot of lacuna in these kind of studies.
I think the score that was used was the Oxford Shoulder Score, which is a patient-reported outcome measure. And okay, you know, personally, I don't have a gripe with that. The whole aim of the reason we exist is to make patients better. You can do a beautiful operation, the X-ray looks brilliant, you're very happy. And if your patient is not happy, your operation is a failure. You do an operation, the X-ray looks absolute rubbish, but your patient's delighted and brings you gifts. You know, that is the best operation that you've done. So, but the bottom line is that this group of patients, the PROFA trial, was the situation where surgeon was in equipoise. You're not sure what is the best treatment. In that case, don't operate.
Actually, such studies are being reported from other regions as well. Distal radius, calcaneus. I mean, this controversy of operative versus non-operative. I think more trials needs to be done in these, more RCTs to be done.
Yeah, totally agree. Yeah. I think can we go on to the next talk, like same fractures in elderly and when to replace, how to replace, what kind of replacement, and tips and tricks from Kapil. Over to Kapil.
Sure. You can see my screen now?
Yeah, it's good.
Yeah, okay. I'll just put it onto play mode just a second. So I'm going to, thanks for the invitation. And my remit, the remit I was given was shoulder replacement and proximal humeral fractures, and share my experience of technical tips, failures, pitfalls, and I'll happily take any questions. I hope we'll have more questions for this one. So this is the problem we are dealing with. You know, Vikas has very elegantly shown us that these type of fractures are a big burden on the society. You look at the epidemiology, and there's a big peak of these proximal humeral fractures in the above 60 age group. As the bone density decreases, These are lower injury, but fragility fractures. And there's a huge burden along with hip fractures and distal radius fractures. And the problem is these fractures, although they are low energy, there's still a degree of comminution. Vikas has just showed us the degree of osteoporosis and the comorbidities in his lecture as well. But more importantly, it is the ability of these patients to cope with rehab. We know that whenever you treat these injuries, whether you treat them with fixation or you do a replacement, there is prolonged rehab. And for that patient in this age group, to comprehend your instructions about exercises and then to cope with them with a period of sling immobilization is extremely difficult. So I think the problem does not end once you've treated this patient with your surgery. Probably the problems start once you've put your knife to skin and how you deal with it thereafter. And the decision how we treat these, again, I keep referring to Vikas's talk. The decision that you make is not only just what you see on the X-ray, but what is the patient in front of you? What is the patient's demands? Is the patient able to cope with the rehab afterwards? How long is your operation going to take? Is that the best option? So the perfect treatment, if you were to do, would be to achieve near perfect reduction, have enough stability so that you can move this shoulder and arm soon, ensure soft tissue reconstruction so you've got good cuff function, and of course, utopian dreams of no complications afterwards. But unfortunately, that does not exist. And these are the challenges we face when we are dealing with these fractures. We want good hold in the humeral head, in the shaft. We want to restore the biomechanics, but at the same time, we want to minimize soft tissue injury. We want to minimize any vascular damage to the fractures, and we want to minimize any risk of late complications. And as Vikas alluded in his talk, one of the big risks of treating these fractures in any way is the risk of humeral ischemia, which does not necessarily mean that the fracture does not heal or you should not fix them, but that is your prognostic factors are in terms of where is the fracture site, how big is the calcar, and how much displacement or disruption of the soft tissue hinges. And Hurtle's paper did show significantly that these three factors are the ones which include, which determine the risk of avascular necrosis after treatment of these fractures surgically. And this is a number of my cases, and you can see that these, you look at these and they are difficult things. And some of them are not amenable to surgical fixation. So what is the option then? What do you do? Do you go and fix them in, rather unsatisfactorily and lead to all these complications? Varus collapse, tuberosities escape, there's no tuberosity here, the screws have penetrated, or maybe I should have, or someone should have done something different here. And this problem was recognized by Charles Neer long ago. And of course, we are all aware of his classification, but he was the one who introduced the concept of replacing the proximal humerus articular surface in fractures which were not reconstructible. Yes, we have got better implants now, but the bottom line is that the underlying bone and the patient still are the same. We haven't changed that much significantly. And he showed good results with his hemiarthoplasty for fractures. So what are the current indications? Where would we use this? The risk of, if you have got a high risk of AVN, maybe don't replace it. Fracture dislocations, head split fractures, and then age. And age I put on a question mark because I think, is 65 too old or is 75 too young? I don't know about that. I look at the patient and that's all very different when you look at the patient. But these are the broad indications, but we're going to delve them into a little bit deeper as to what kind of replacement we're going to use, if we're going to do a hemiarthroplasty, what we're going to do, and how we get a successful hemiarthroplasty. Because that is the key. Most of us grow up in orthopedics putting in hip hemiarthroplasties, and we think, we can put in an uncemented hip hemiarthroplasty in 20 minutes. So I'm sure we can put in a good shoulder hemiarthroplasty. But it's a very different beast, this one. Think of, and this is for the younger members of the audience, when you want to do a shoulder hemiarthroplasty, think for a second, can you do a hip hemiarthroplasty in a 4-part proximal femur fracture where both the trochanters have gone, you've got no abductors there at all. Can you do it satisfactorily? No, you can't. And that is why it is very important here. Because the success of your shoulder hemiarthroplasty will depend on, most importantly, how you put it in, whether your height is correct, whether you put it in the correct orientation, and if your tuberosities are going to heal. If you fail on any of these, you will not get a successful operation. And all you would have done is given the patient a scar and a metal spacer in the shoulder, which doesn't work and is painful. So if you're going to do a hemiarthroplasty, and I'm sure a lot of people still do them, what are the key things? As I said, height, offset, get the tuberosities right, and get them to heal. Now that's a big task. We already know that these patients have got poor bone. We were not fixing them because we were worried about fracture healing. And now we want or expect these tuberosities to heal to a little bit of metal and to the humeral shaft. So how do we go about achieving a successful shoulder hemiarthroplasty? So let's look at the height issue. Now we know that in you've got a proximal humeral fracture, a lot of your landmarks are lost. But most of the times you've got this big medial calcar spike and the area of the bicipital groove is intact. That guides you as to where you should be positioning your hemiarthroplasty. You can reference the height from the top of the pec major. So from the pec major insertion to the top of the prosthesis, about 56 millimeters. And your greater tuberosity should be about 1 centimeter or so below the top of the humeral head. So again, be mindful of this. If you've got a very comminuted fracture where you have lost all proximal landmarks, don't hesitate to get a scaled radiographs of both arms. I've never done it personally. I eyeball it from the medial spike, but that is something which you can do if you're really not sure about what your height is going to be. I'm just going to stick here for a second. The other issue is version. Now, if you take a straw poll of all the audience, they will tell you that everybody puts them in about 30 degrees of retroversion. But there is a huge variability in the version of humeri in the general population. It goes from about 5 degrees of antiversion to nearly 55 degrees of retroversion. So there's about 60 degrees variation. So again, for version, my tip is align the bicipital groove here. And then once you've got the bicipital groove facing straight forward, the humeral head should be pointing towards the glenoid. And that is a rough version guide by which I work. The next question is dealing with the tuberosities. I think this is the most critical part of your operation. In my opinion, the hemiarthroplasty is a soft tissue operation. Which relies, sorry, I'm just getting a lot of feedback.
I think somebody is using 2 devices.
Yeah, it's not me, somebody else.
I think
Yeah,
Ramesh.
please, who is using 2 devices? Anybody logged in with mobile, please? Dr. Harmesh, mute yourself.
Already muted.
Oh.
Okay, I'll carry on.
Yeah, you carry on, sir.
Yeah. So in my book, this is a soft tissue procedure. So what you do is you have to make multiple drill holes in the shaft. You have to pass sutures through the rotator cuff rather than going through the tuberosities. The tuberosities are very osteoporotic. If you try and pass sutures through those, you will cut through them. So go through the muscular tenderness or the osteotendinous junction in the rotator cuff and pass these multiple sutures. Then I'll show you in a schematic here. So this is one of my cases. As you can see, it's sutures all over once you have finished the operation. So you've passed these sutures through the posterior part of the cuff, you've passed the sutures through the subscapularis, you've got holes in the shaft, and you've got holes in the prosthesis. So essentially you have got a combination of horizontal sutures, which act as circular sutures, they hold the 2 tuberosities together. And then you've got vertical sutures, which act like tension band to detension the pull of the rotator cuff to get them all down, okay? And this is a paper from Pascal Bolo on the technique of hemiarthoplasty. So again, it illustrates, you pass your sutures through the shaft, you pass your sutures through the infraspinatus and teres minor, and then you circle arch through the subscap, bring the two tuberosities together, and then you use the shaft sutures to pull the tuberosities down. And at the end of your operation, this is what it should look like. You should have restored the Gothic arch here. So you can see that the humerus is very well centered. The tuberosity, although fragmented, is below the level of the humeral head by about 1 centimeter or so. So this is what you should end up. And I personally always cement the stem in. These patients are osteoporotic. You need good fixation of the stem so that it doesn't move in the canal and lead to more instability or lack of position. So I always cement the stem in fracture hemiarthroplasty. So for me, key to success of a fracture hemiarthroplasty, hemiarthroplasty in a proximal humeral fracture is patient selection. You must cement the stem and be very careful with your tuberosity management. But then does it always lead to success? No, this is a case done by one of my colleagues, and you can see that the tuberosities have vanished and it needed a revision to a reverse. So again, it does not work all the time. And the reason, and if you look at the literature, you will find that the reasons for lack of success in hemiarthroplasties are essentially all related to the tuberosities. So this paper from Korea, 18 out of 33 cases had poor healing of tuberosities. And a randomized control trial between non-operative treatment with hemiarthroplasty, no difference in terms of quality of life or function. And there is a number of other papers which again look at the same thing. Now this was hemiarthroplasty versus non-operative. So there was less pain in the hemiarthroplasty group, but there was no significant difference in range of motion. And the reason for poor function in hemiarthroplasties is implant alignment, as I said, discussed the version, the height. Now you can see in this case, there's been excessive bone loss proximally, there are no tuberosities, and you can't expect this dead piece of metal to work because there's no motor to it. This is another case which was referred to me. You can see that the proximal humerus is riding high. It's next to the acromion. The prosthesis is very, very proud. The tuberosities have not been brought back down and it needed a revision to a reverse. So, if you're left with this is not a good result. And the reason this is not a good result is because now you've got a cuff deficient shoulder with a metal bit, which is now painful, and the patient's got very poor shoulder function. And to me, there is no difference between this cuff tear arthropathy X-ray and this failed hemiarthroplasty, except that there is a big bit of metal here, which you have to take out to give this patient any useful function. And that brings us to the reverse replacement. Now we know that reverse shoulder replacement gives you excellent results in cuff tear arthropathy. The functional results are very good. Yes, there are complications, but I think as we get better at it, we are able to give our patients reliable, good results. And if you look at the literature evidence of comparing hemiarthroplasty and reverse shoulder arthroplasty, you will see, like here, reverse shoulder arthroplasty result in better clinical outcomes. Again, this is a review which says available literature suggests reverse shoulder arthroplasty gives you most favorable clinical outcomes. So is this the answer that we've got? Yes and no. Yes, because done in suitably selected patients, you will get a good functional outcome, but there are problems. And there are problems which are very similar to doing a hemiarthroplasty, but this is more extensive surgery. And if it goes wrong, then you and your patient are in much deeper trouble. So let's look at briefly the technique for a reverse arthroplasty in fracture. Approach, it's up to you. You can use a deltopectoral approach or you can use an anterosuperior approach. I've done both. Presently, I do everything through a deltopectoral approach because I do a lot of revisions. So I just stick to one approach now. But you can do an anterosuperior approach, which gives you excellent visualization of the glenoid. The glenoid exposure in a fracture reverse case is much easier because you've lost all the tuberosities. The tuberosities are all gone. They're not attached to the shaft, and you can retract them and you get a very good view of the glenoid there. But the trick is the humerus. And the humerus, the issue is again the same as in a fractured hemi. What is the height, the version, and your prosthesis design? You don't want a very bulky prosthesis which doesn't allow you to reattach the tuberosities. Now, you might argue at this stage, you don't need the tuberosities because this is a reverse shoulder, so you don't need a functioning rotator cuff. But I think it's important to get your tuberosities to heal because A, it gives you stability. The risk of dislocation after a reverse is reduced if you get a good cover of the two tuberosities. And B, you get better functional outcome in terms of restoration of rotations of the patient as well. So I use this Mathis system, which is a convertible system. So I've got a diaphyseal component which I cement in, and then I can either put on a fracture inverse or a fracture prosthesis or a reverse prosthesis. So I can do that. But you see, this is a coated prosthesis proximally with a number of holes to reattach my tuberosities with transosseous, with sutures. So again, attention to tuberosities is exactly the same as if I was doing a fracture hemiarthoplasty. I borrowed these slides from a colleague of mine who uses these cables, while I use these sutures to fix it. Because as I said, they contribute to stability and restoration of function. And this is a review article from Amarangan's group, and they looked at whether tuberosity healing made any impact on the final outcome. And they definitely found better range of motion, especially forward elevation and external rotation, if the tuberosities had healed in a case with reverse for fractures. So this is one of my patients, 70-year-old lady whose exercise I showed you earlier. I deemed that this fracture was not fixable. And at that age, my default was going to be doing a reverse. So this is what I did. I have managed to pull the tuberosities down. They may not be in the best position, but they're there and thereabouts. They're very comminuted. And this is her functional outcome. And I'm very happy with that. Yes, it's not 100%, but she's got no pain. She's got very good function. She can self-care. And the other thing which I've noticed is that the rehab with doing a reverse is much quicker than doing a hemi or fixation. I keep them in a sling for about 10 days and then I get them moving. And I've not seen tuberosities escape, probably because it's a reverse and the mechanics are different. And hence the cuff doesn't pull on the tuberosities, but that's been my experience. But there are complications, as I said, the big complications for me for reverse, the biggest complication is instability. And that's primarily either the components have been malpositioned, or this case here was a patient who was operated on abroad and the humeral stem was in complete wrong version and we had to correct it, or over enthusiastic excision of the proximal humerus here, which leads to poor support and no soft tissues to contribute to your stability. So my view is try to fix most fractures, consider hemiarthoplasty as a operation in the slightly younger patient, but treat it as a soft tissue procedure to reattach the cuff and tuberosities. Version, the height, and the tuberosity healing are the key to your success. With a hemi, there is significant risk of tuberosity escape, and be mindful of that. Reverse shoulder arthroplasty gives you more predictable results, but you need to be confident that you're going to do a good job for you and your patient and yourself. And you need to be able to understand the nuances of reverse shoulder arthroplasty. So this is my treatment algorithm. You can read it for yourself. So if you can fix it, fix it. If you can't fix it, then your options are here, whether you go to a reverse or to a hemiarthroplasty. If you've got good tuberosities, younger age group, do a hemi. If you've got an older patient, poor tuberosities, then go down a reverse route. Thanks very much.
Thank you, Kapil, for excellent and very clear presentation on this complex topic. I think there are going to be some questions. So I think the way you're saying, I think a lot of reverse shoulders are being done. I think hemi is literally going out of practice in your practice, maybe.
Yeah, I think
you
even
still do hemis or
no, if you look, even if you look globally, the reverse rates are going up. All registry data will tell you that more than 50% of all shoulder replacements done now are reverses. But particularly for fractures, you're absolutely right. If I'm treating a fracture, my endeavor is to fix it, and fix it. And if I can't fix it, then Most of the times I will end up doing a reverse rather than a hemi. Very, very rarely, if I've got a very, a patient in their 50s with a very badly split head, which I can't fix with screws or anything, then I might do a hemi. But most of the times, if a patient needs a hemi or a replacement for the proximal humeral fracture, I'll end up doing a reverse.
So you keep both the implants ready in the OT for because you try to fix, and then if you're not okay.
Yeah, we got everything on shelf, so we can go from fixation to hemi to that. In fact, the system that I showed you, so that is just one tray. I can go to with the same diaphyseal component, I can either put on a metaphysis for a hemi or for a reverse. So it's all interchangeable. And if you have time later on, I've got 1 or 2 cases of trying to show you how easy a revision is with that kind of system.
Any other questions from the faculty and the panelists?
Yeah, Dr. Vijay, can I ask one question?
Yeah, Dr. Vineet, yes, please.
Yeah. Dr. Kapil, very nice presentation. We just want to know, if we are not able to fix a fracture, so shall we first try hemi and then we think of reverse, or should we directly go for the reverse?
No. You see, the more operations you do, the more problems you'll end up. So if you've got, in my practice, if I've got somebody above the age of 65 where I can't fix the fracture, I'll go for a reverse. So the results of a revision of a hemi to reverse, I didn't have time to go into that, but a primarily done reverse is much better than a reverse done in a revision situation. Your risk of infection and all other complications goes up in a revision situation. However, it's very interesting. The other dilemma that I can put it to you the other way. If you're not sure whether you want to treat the patient operatively or do a reverse, you can give them a trial of non-operative treatment, see how they are, and if at 2 or 3 months' time your functional outcome with pain and function is very poor, you can go and do a reverse. And the literature would suggest that there is not a significant difference in the outcome in a reverse done primarily or after a trial of non-operative treatment. But remember, because you see, you don't have the scarring and the stigma of a previous operation, that is the other issue. The other issue of changing a hemi to a reverse is if you've got a well-fixed stem, removing the stem is extremely difficult. Very few, you can use a platform system, but if you have put the initial stem in a wrong version and the version changes, in a hemi, you're trying to replicate normal retroversion, which is about 35 to 40 degrees, while in a reverse, you're going in neutral or about 10 degrees of retroversion. So again, that has changed. So it's probably better to do a virgin operation than to do a revision operation.
Dr. Tahir, I think you also had...
Dr. Vijay, there are no questions that come from the audience.
Okay.
So you can continue with
right.
discussion.
So I think one request to make, please keep yourself mute during the presentation. I think there was a lot of disturbance in this talk. I think twice Dr. Kapil had to stop. So I think then we go to the next talk. Now the challenges in the management of distal humeral fractures in elderly patients. So Professor Kotwal sir, I think. Thank you, sir.
Am I audible? Hello?
Yes, sir. Yes, sir.
Okay. I would like to thank the team DOA, Dr. Vijay Sharma, and Dr. Manish and Dr. Sharad for giving me an opportunity to talk on the fractures of the distal humerus in the elderly and the challenges that we face in its treatment. In 1953, Evans described a method, bag of bones, actually just giving, particularly in patients who have comorbidities and not possible to operate, and just give a cast and cuffing collar for 2 weeks, followed by mobilization. Actually gone are the days. Now, non-operative treatment may be appropriate in some elderly patients, but that results in loss of motion and unsatisfactory results. Therefore, the ORIF is the gold standard, but may not be possible in the elderly always, that we know, because of the challenges that we face. One is, of course, it has been said, and we all know that the problem of osteopenia and osteoporosis. The fractures because of this are generally highly comminuted. Not only the comminution, but there is articular fragmentation. So restoring the articular congruency also is a major challenge. Then because of the osteoporosis, the incidence of implant failure is very high. Then the chances of non-union, not only of the fracture, but even of the osteotomy site of the olecranon also, the non-union is very, chances are high. Then of course, the other complications of infection, recalcitrant stiffness, and sometimes there may be associated conditions like rheumatoid arthritis. So all these actually pose as challenges for the internal fixation. And therefore, it has been reported that the open reduction internal fixation yields less predictable results because of, as I said, osteoporosis, metaphyseal comminution, poor soft tissue conditions, and limited tolerance for joint immobilization. However, one can definitely be able to achieve a good fixation, good ORIF with the help and reconstructing both the columns, and of course with the help of doing an olecranon osteotomy. And this is another case. This was actually a delayed union, and we had to use a fibula and a bone grafting to be able to fix that and reconstruct the columns. But this is not always the case, as I said. And there are various problems like this. There is a major problem of bone loss leading to non-union. And you can see here, there is this medial column is missing, which actually requires a large bone graft, and may also, if it is not possible to reconstruct, may require total elbow replacement. And this is the lateral view of the same patient, the implant failure because of osteoporosis. And the CT scan shows the silver lining here is that the intercondylar, this thing is healed, and the problem is only now with the reconstructing the supracondylar if it is possible. And obviously there is a loss of medial pillar with non-union and implant failure, as I already said. So now what to do? And therefore, this was reconstructed by using a large chunk of corticocancellous bone from the iliac crest fitting into this gap and fixed with the plates. And this actually healed very well, and the patient had good satisfactory functional result. Another scenario, something like that, there is so much of osteolysis, absorption of the bone and the osteoporotic bone. So this is actually certainly is not a good case now for doing any osteosynthesis. However, one can still do that. We actually tried doing again the same thing, and of course increase the bone stock by using a fibular bone graft, and this obviously has healed. The fibular bone graft has partly been incorporated, but some of it is yet to be done, but generally the fracture is healed quite well. Another situation, this kind of thing, now there are no articular surfaces that you can see, and this is the kind of this thing which will require a total elbow arthroplasty as done in this case. And nowadays the total elbow arthroplasty, like for the shoulder, has become an extended indication in trauma, and with an aging osteoporotic population, which are not amenable to osteosynthesis, may require replacement more often. And the supporting the TEA, and these are the various articles which actually support the indication of total elbow in the trauma. An example, a non-union with a bone loss, 72-year-old lady, osteoporosis and medical comorbidities, and it's quite a distal fracture, and if one is able to still fix it, maybe the fixation may be a problem, and then the problem would be that of the stiffness. So this was is a good case for doing total elbow arthroplasty primarily, and this is the position, lateral position, and you give a midline exposure, identify the ulnar nerve, and there are various ways of opening it up. You can do an olecranon osteotomy. I prefer to do an extra-articular osteotomy, and get a good exposure. And there is a small chunk of bone taken away with, along with the triceps muscle. And then this is the femoral canal. You are doing preparation for the femoral canal. That is the radial head that you can see. And this is the jig, which with you will make the cuts and for fixation of a trial prosthesis in the humerus. And this is the preparation of the ulnar component. And this is the trial, and this is the ulna, which has been prepared now. And you put in the prosthesis, the ulnar component, and the humeral component. And of course, this is the putting back the olecranon and fixing it with maybe just 1 or 2 wire sutures, or even simply non-absorbable suture is also good enough. And this is the post-op X-ray of the same patient after total elbow replacement, and that's the range of motion after a good therapy program at the end of about 3 months. However, total elbow replacement in that age is not without complications, and there are a few complications. Deep infection, which is about 2 to 5%, although it is declining with the use of antibiotics and maybe with better surgical techniques. Ulnar neuropathy is actually quite high in reported is 28%, and that is where there lies a debate whether to transpose the ulnar or anteriorly or not. So this is another reason for that debate. The triceps insufficiency, particularly in the elderly, the soft tissue and the muscles are not that strong enough, and that can also lead to insufficiency. Then the instability is a problem. Then the fatigue fracture of the implants, bone loss, as I showed earlier also, and even after the total elbow, there can be a bone loss, absorption of the bone, and periprosthetic fractures like it occurs with any total joint replacement anywhere. So I'll tackle them one by one. This is a post-infection scenario. This was the total elbow was done elsewhere, and the patient developed a infection and a deep infection, which actually had to be, the implant had to be removed. This is what we did: remove the implant, put in a cement spacer, control the infection. 3-4 months later, we went in and did a post-infection stage revision, total elbow replacement. And this was the result. That's the extension, and that is the flexion at the elbow joint. Triceps insufficiency. You can see here. Look at the quality of the triceps and the muscle here. So this actually is triceps. Obviously, you have to have a good triceps to be able to get movements after the surgery. So after the proper debridement and you get good muscle bed, then you obviously have to take a fasciolata, or maybe you can take a reflect part of the muscle and the tendinous part of the triceps to be able to suture it back as much as you can and to remove that deficiency. This is another case of an elbow with bone loss. You can't make out which bone is which. One of them obviously is ulna, and one of them is the humerus. And this is what the X-ray looked like. That's the so-called elbow joint, and we still decided obviously no way to do any osteosynthesis. So we decided to do a total elbow replacement. This was the pre-operative planning to make an entry into the distal part of the humerus, and this is how we perform the elbow replacement. And this is the result at this thing. And one of the complications I said is the instability. So I would like you to see this. The patient has instability. Look at this. So the forearm swings away. So this is a complication certainly after total elbow replacement. And obviously he has all the ingredients for an instability because there was that much of bone loss, but still nonetheless the function is reasonably good, except that's instability. Then we advised him to use a elbow cage kind of brace and not to use this hand for lifting heavy weights. Fatigue failure of the implants is also a known complication for which you need a revision, and you have a little longer stems for doing the revision arthroplasty. And so this is a longer implant for use for this thing. Of course, the sometimes the availability of the implants here is not that complete. You don't have the full sizes and everything, but still we managed to kind of do that. And this also has a good range of functional range of movement. Problem of periprosthetic fractures and bone loss. This was a case done elsewhere, and then he came to us, and you can see here, this is all haywire, and we still anyway went in with the preparation of removing that prosthesis because this was doing no good. And when we went in, this is what we found. This is the distal end of the humerus. There's just one cortex left, and we didn't know what to do, but we decided to take a chance. Took an outer cortical cortex bone graft from the iliac crest and reconstructed a canal of the distal humerus. And through the ulna here, we still managed to put in a prosthesis. And this is the prosthesis put in into the reconstructed canal of the humerus. And this is his functional range of movement with reasonably good stability. This is much better than looking at what the kind of elbow, so-called elbow joint that he had before surgery. I will end up with a really challenging case. This one was an elderly person from Punjab, and he was operated earlier elsewhere, kind of, where the osteosynthesis was done using this kind of double plates. When the fracture had not united, that you can see. The implant had failed, was not holding properly. You can see in the other view as well. Then I don't know whether this was actually a fracture in the olecranon, or whether this was the so-called site at the osteotomy and in the olecranon, which had also not united. So then because of all these things, the second surgery was done again outside somewhere. They tried to remove the plates, and a temporary stabilization was done with K-wires. And there was obviously bone loss here. You can see here now, the bone has been removed. That is perhaps because of even on this X-ray, you can see there are signs of infection. So maybe because of the debridement that they must have done, the bone loss is there. And this seems that, the tension band wiring has been done again. And because the position of the wires is different, but still, whatever that fracture or the osteotomy has still not united. So at this stage, he came to us, and this was his surgery number 3, the patient's third surgery. So what we did the removal of the implant. We did a thorough debridement, and after that, this was after 3 or 4 months under antibiotics and this thing, we called him, and at that time, when we are confirmed that the infection, all the markers had come down to normal, then we tried to do a fixation for the olecranon or whatever this non-union. We tried to fix a plate and did bone grafting, because for putting the olecranon stem, you need the ulnar stem. I mean to say, you need an intact olecranon. So we decided to do a plating and bone grafting. And this is the surgery number 5 for the patient and third surgery by us. Now at this stage, we removed the olecranon plate, because an operation also this was looked united, and we did a total elbow replacement with these stems. And this is actually a challenging job, because you do not have any condyles, you do not have any bone landmarks. And so therefore, the positioning of the prosthesis has to be done by eyeballing and trying to get the correct tension at the elbow joint, so that the prosthesis is neither too loose nor too long. And this is what we could achieve. This is the humeral component as the ulnar component, and we could achieve and do. We did not try to unnecessarily meddle with the with those fragments which were actually not coming in our way. We actually looked at only getting into the prosthesis into position, into place. And generally we give this kind of turnbuckle brace to the patient so that they use the turnbuckle and so try to get flexion and extension at the elbow to get this kind of result. Obviously, and at the end of about 3 to 4 months, he has a full range of movements at the elbow joint. So to conclude, the fractures of the distal humerus pose multiple challenges in the elderly. Select cases can be treated non-operatively, although the ORIF remains the gold standard, but results generally result in less predictable outcomes. And therefore, the total elbow arthroplasty is a good option. And obviously, total elbow arthroplasty, of course, is not without complications. But whatever the method, meticulous surgical technique and good post-op therapy yields good results. Thank you very much for your attention.
Thank you, sir. There's always so much new to learn from your lectures. So thank you, sir. And any questions from the faculty or the panel? So if there are no questions, then we'll go on to the next talk by Dr. Dr. Harmesh. You want to ask something?
Yeah, I just wanted to know, sir, total elbow replacement, what are the options right now available in Delhi, state of Delhi? Which implants are most popular with you, and what are the pros and cons?
See, earlier we used, we've been doing it for nearly 35 years. And earlier, the only implant available to us was the Buxy's sloppy hinge prosthesis. Even that is also available now, although it must have changed the vendor, but it's still available. And which is generally affordable to our patient. The cost is much low. But generally, we now do the brand Mori Homedica prosthesis, which is actually expensive, but this is definitely better in terms of instrumentation, in terms of the technique and everything. So there are, again, unfortunately, not a very wide array of implants available as you have in hips and knee. So there is definitely not much limitation on that.
So these are all constrained or semi-constrained, or there is option during the surgery you can switch
many, but they are generally semi-constrained.
Right, sir, right. Thank you, sir. I think we now. Harmesh, you want to say something?
Yeah. So as in shoulder and in hip, is there something called reconstruction or reattachment of the soft tissues in elbow also, or it is just a cemented implant and just lock it in and?
Yeah, it is a cemented implant. The only important thing about this thing is restoring the extensor mechanism, because the approach is from the posterior side. So the restoring the extensor expansion is the most important thing, number one. And like I showed, the cases of triceps insufficiency and all that you need to restore that. And the second thing is about the correct the tension in the correct placement of the prosthesis, that it should not be too loose. Actually, if you are doing it in a rheumatoid, if you are doing it in a rheumatoid where the condyles are, unless it is not too much destroyed, the condyles and all this are there, the jigs are there, you put those jigs and you can get the correct this thing. Whereas in trauma, particularly in our scenario, like the example that I showed, there is there are no condyles, no normal anatomy. So this is actually a challenging case. But yes, again, coming back to this thing, there are two things. One is restoring the extensor mechanism and obviously the correct tension of the prosthesis.
Sir, when their ulnar stem is inside, when ulnar stem is inside, we can't put in the TBWs, normal wires that we usually put to fix a olecranon osteotomy. Similarly, we can't use a plate. So then how do you ensure that it is well fixed, or do you use these implants?
No, this is actually, see them. Otherwise also the ulna in our patients is really very thin, number one. And once you put that, most of the times the implant, the sizes available, we generally require the smallest implant, that's number one. and then the cortex is not that thick to be able to pass those tension band wires in the circular structure and everything. And the another important thing is also putting a cement, because the canal is very narrow. It's not like the femoral where you can easily put in a either in THR or TKR, you can put in the cement properly. So there is actually a difficulty in this. You have to use fine tubings and all those things to be able to push the cement into the canals.
Thank you, sir. Dr. Kapil, you want to make some comment or some question? I think you have unmuted yourself.
That was excellent presentation, Dr. Kotwal, and some real very, very challenging cases that you get. But I'm just going to put a little word of caution, if you will allow me to, sir.
Yeah.
You've got a lot of experience doing elbow replacements, and I think your technique of osteotomizing tip of olecranon to reflect the triceps and reattach it back is novel. I've never seen anyone do that, but you seem to be able to manage the triceps with that way. For the younger members of the audience, I think you need to be very careful with the triceps. Detach. If you lose the triceps in an elbow replacement, it is like losing your abductors in a hip replacement or anything, or your quads in a knee replacement. It doesn't work. So there are alternative approaches by which you can still preserve the triceps. So you can do a triceps on approach like the Mayo Clinic approach, where you reflect the whole triceps as a oneer from medial to lateral, or you can do a Campbell's turn down, where you turn down a tongue of triceps and then you split the triceps. And in fact, in a lot of trauma cases, you can actually do a paratricepital approach because the condyles are lost. You've got enough room to go and leave the triceps attached to the olecranon, and you can do an elbow replacement. But unless you're very confident that you'll be able to securely fix your olecranon tip after your elbow replacement, I think it is an expert. Leave it to the experts to do it. I would advise. This is really adult surgery if you're doing that triceps olecranon osteotomy and fixing it back. But the other thing which Harmesh Kapoor asked about soft tissue attachments, none of the elbow prostheses have got the ability for these transosseous sutures. But if you're doing it, unfortunately, that prosthesis is not available in India, is an elbow hemiarthoplasty. So in the slightly younger patient where you can't reconstruct the articular surface, you've got the option of doing an elbow hemiarthoplasty. And the difference between a elbow hemi and a total elbow for fracture is the integrity of the ligaments. You can forget about the ligaments using a semi-constrained Conrad-Maurer prosthesis. Even if you don't have ligaments, it works fine. But for a hemi, you really want the ligaments to be attached. So that has got a hole through the spool of the distal humerus, where you can pass the sutures from your ligaments and tie them to each other on the opposite sides, which reattaches your ligaments. So I think that is important, just to answer that specific question about prosthesis with ability to reattach the soft tissues. Of course, when you're in the territory of distal humeral replacements or total humeral replacements, you've got various prostheses for tumor reconstructions. You've got prostheses for soft tissue attachments with sutures.
Can I just make a comment? We don't have, like you rightly said, we don't have the hemi replacement prosthesis, and I have no experience with this. So I did not talk about it, number one. Number two, the kind of cases actually that we generally get in, like I have shown a glimpse of some of those cases. And they are, it's like third surgery, fourth surgery, second surgery. So you definitely need a very good exposure and got to know what bone is what and all those things. So therefore, rather than doing the other approaches, trap or any of those, like you mentioned them, actually I wanted some of an exposure, which will actually give you a very good view at what you are doing or what you are cutting. So that was the reason. But yes, you have a point there. And generally, I would make either holes into the olecranon. Before you make an osteotomy, so that you'll be able to put that thing back in a proper position, and would immobilize the elbow for about 2 weeks or so, in any case, before the stitch removal, and then gradually start. And of course, I showed that hinge, this thing. So along with that hinge, we are comfortable to start that removal. And I actually had Dr. Tahir with me when I was at AIMS. So he must have been a part of some of these cases. So I also acknowledge his help and contribution in that.
So that's what I'm saying. When you show the experts doing an operation which they can get away with and the technique which works in their hands, we just need to be cautious that People with average surgical competence may not be able to do that. So you are very lucky that way, sir.
Thank you.
I think we will move to the next lecture by our young dynamic consultant, Dr. Mohammad Tahir Ansari. I invite him to talk on changing trends in the management of distal radial fractures in elderly patients. Dr. Tahir?
Good evening, everybody.
Yes, you are audible. Yeah.
Yeah. I'm highly thankful to DO team for giving me a chance to present this lecture. And I'm highly thankful to all my seniors who have always guided me for the right kind of treatment for this kind of fractures, basically. And the objective of my talks are a quick review about the literature, because it is changing. It has changed a lot in this decade. And I like to identify the difference between the young adults and the treatment among the elderly. The treatment options available, the complications, and then I will discuss try to develop a consensus for the treatment. So elderly fracture management disorders has increased attention in this decade, and because the elderly patients are one of the fastest growing population segments. They have a longer life expectancy nowadays. They have more active lifestyle. It is frequently not the infirm, but rather healthy and mobile elderly individuals that sustain these injuries. And if you see our population now, most of the elderly people are independent lifestyle. And the other population that we see, they are doing different jobs even in this age group. So radiocarpal articulation is important for everybody. And to make them independent, they can have an independent life. But it has an increase. If these are not treated in the right way, then these fractures have increased morbidity. The patient will have poor quality of rest of the life and definitely increased suffering. So these fractures are most common approximately fractures after 65 years of age. There's a marked gender disparity. These are more common in the women after the age of 40 years. There's six-fold high increase among the women between the 60 and 94 years. So if you see, around 20.8% of the women and 4.6% of the men will suffer a distal radius fracture after 50 years. So this is a huge morbidity basically. And only 50% will report a good functional outcome at 6 months, and 30% of the individuals may suffer some long-term complications, as has been reported in this paper. So this is a huge number that this radius fracture in this age group, and these are associated with dementia, poor eyesight, decreased coordination, and independent and socially dependent individuals. So we have to be careful, take care of these things also, not only the distal and radius fractures. And there's a difference between the young individuals and the elderly individuals, because in the young individuals, this fracture happens in the result of the high energy trauma. And elderly population, they may have a trivial fall in the bathroom or in the park or going somewhere just from a standing height. So as the age increases, the fewer demands on their extremity. There's lesser need of full illustration of the primary injury anatomy. There's a very big question mark because the demands are changing, and we have to be careful how we deal with these fractures. And if we talk about the age, we have to think about three types of ages basically: physiological age, actual age, and the perceived age. Actual age is obviously the actual age. The physiological age sometimes may vary because individuals may have an active lifestyle, and we have to discuss with the patient because how the patient perceives themselves. Usually, if you ask somebody what's the age, so they stay around 50 years or 60 years for 20 years. So sometimes patient have a different perception about his or her age, and we have to. The only determinant is the physiological age, the level of function. If you really want to classify these or objectify these activity level, then we can use a physical activity scale of the elderly for research purpose. Bone marrow, BMD becomes important in the bone mineral density in distal radius fractures because there's a severe decline in women after menopause. although BMD assistance is recommended by the WHO, but majority of these fractures these patients have, these are not investigated for osteoporosis. This is also a concern because these all should be investigated. If we see the bone mineral density, it decreases in women, and 85% of the patients have a low osteopenia, and 51% will have osteoporosis. So this is a huge number. We have to treat the BMD also, and it affects the fracture healing. The fracture healing takes longer time. There is longer duration of protection has to be given, a slab or something as splayed. There's 50% risk of secondary displacement after close reduction splitting. The risk of displacement, which increases with age. There's difficulty in maintaining reduction without surgical treatment. So the risk of displacement becomes, there are some cumulative factors. These are very important. If the age is more than 60 years, if there's more than 20 degrees of dorsal angulation, more than 5 mm of radial shortening, dorsal combination, ulnar fracture, intra-articular radiocarpal involvement. So these are the factors which has to be taken care of when we are dealing with this kind of fractures. And still the gold standard is the conservative treatment, and is the most common and can be used for most of the patients for minimally displaced fractures. And people have tried to compare the radiographic appearance with the functional outcome. So there is no correlation between the radiographic appearance and the functional outcome. And elderly individuals are believed to be minimally impaired by fracture malunion. And if this fracture malunion is severe, then only it affects their function. And this study has shown that if there's angulation of more than 30 degrees of dorsal angulation or more than 5 mm of radial shortening, and this can be well tolerated. But redisplacement does not have any effect on the function. But if there's a marked loss of reduction, and that leads to compromise in the function. So it has to be taken care of that the marked deformity is noted. And poor functional outcomes have been observed when radial shortening has exceeded more than 6 mm in patient with age of more than 69 years. And other study has shown that when the displaced malunion of more than 10 degree angulation or more than 2 mm radial shortening affects the function. And 18% of patients had decreased subjective satisfaction. So the literature is quite confusing regarding what is the status basically. And there were multiple factors have been used, efforts have been used to prevent the displacement after reduction. And pins in plaster, this has been used from ages. And the fracture reduction following pinning represents a minimally invasive approach. This is inexpensive, especially in our country, where it is difficult for the patient. It's difficult to afford a locking plates or costly treatment. Then this treatment can be used, but there are chances of pin-tuck infection and complex regional pain syndrome. AYS alone can be used, but we have to be. There has been a study which has shown the Kapanji technique, the intrafocal technique, which has been found to be a little superior. And whenever we use the K-wires, we have to make sure that it is having a hold in the opposite cortex, because sometimes the K-wires are left intramedullary, and these in osteoporotic bones, these don't have any hold. So then the complication rate definitely increases. The complication rate is quite high. It's around 30%. There are chances of nerve irritation and wire migration. This is 30%, 1/3. So out of 3 patients, one may have this type of complication. External fixators has been used with K-wires. This can be bridging or non-bridging, and the complication rate is around 47%, mainly superficial pin side inspection or broken K-wires. Senseless bone graft can be used with external fixator. So this is the kind of fixation that can be used external fixator with K-wires, but this is all done close or minimally open approach can be used for articular congruity. So this is one of the treatment which can be used. This is less expensive than the locking plate in elderly. And bone substitutes has been used because they develop a large bone void after fracture reduction that may benefit from bone grafting, autograft, allograft, or bone substitute. These can be used, but there are chances of leakage of the bone substitute. Sometimes they cause irritation to the soft tissue. There are chances of carpal tunnel syndrome. This has been used for contribution with external fixator or volar fracture plating. So this is one thing, but with the locking plates which you are using, there are no chance, there are less chances of using these bone substitutes. Open reduction relaxation can be used with volar plates or the dorsal plates. There is sufficient stable fixation even in elderly. There is no need of fracture augmentation with autograft or bone cement allograft when you're using a locking plate. They're left in place and there's no need to require removal such as dorsal counterparts. And volar angle fixed plates, this study has shown there is reduction 40% of the patient was lost at 3 months with conventional T plate, then with a fixed 5% with the fixed angle group. So should not use a conventional T plate, other use if you're using a T plate, then use a locking plate. The open reduction relaxation can be fragment specific or it can be volar locking plates. So as in this case, if you see the X-ray, there is an interarticular fracture, AO type 3A. If you do a CT scan, then you'll see there are 3 main fragments. One is the radial fragment, and there's the radial fragment, and the ulnar fragments are dorsal unit or the volar unit fragment. So these fractures can be treated sometimes with fixed angle plate also if you are going to use a extended FTR approach, or you can use a fragment specific approach. So we used a fragment specific approach, we used a reference plate, and these can be definitely very good. Whole hand patient can be mobilized early. So this is the function of this patient. And volar alone locking plates can be used. These are suitable for elderly patients who may take a longer time to heal. They are with KY, there's a more chance of infection, but with plates, there's less chance of infection. The rate of functional improvement after treatment with volar locking plate system is demonstrated. So I said there's a similar rate of recovery between patient in the young patient and old age patient. So it doesn't so have the age-wise effect. Basically, they will have a similar type of recovery. So whenever we are trying to operate these patients, the soft tissue envelope is very important. If you see so many blisters, so all these patients has to be examined before operation because they have a thin skin and sometimes the soft tissue problem happens a lot. So do operate after a week or so, or operate the same day. So there is a difference if the patient is fit, can be operated, but wait for the soft tissue to heal basically, because otherwise may have a complication rate, a higher complication rate. This is the factor that printed to us. This is sometimes present quite late. So you can see a callus formation there. So these type of fractures can also be taken care of by the locking plate, and you need not to fill this gap with the bone substitute or the graft. The plates are stable enough and patient can be mobilized early, and there's no need of any graft with these plates. There has been a recent RCT in 2019 where they have compared a non-operative treatment using a plaster splint with surgical treatment using a volar locking plate for dorsally displaced fractures. The functional outcomes such as patient-related outcome measures and the dash scores are compared. Grip strength were compared. Below the complication rate was same in both the groups, and there was at 12 months there was equal results, but at 3 months the plates were definitely better. So the plates help in quick recovery, and but after 1 year or so, perhaps the outcomes are same. And this risk trial has come up. This is very important because this came up in 2020, and where they have compared. This was a randomized multi-centric trial which enrolled 304 elderly patients. It was an international trial. In US, Canada, Singapore were involved, and the patient who wanted surgery were randomized into internal fixation, external fixation, percutaneous fixation. The patient who preferred conservative management received cast. So the primary outcome was 12-month Michigan score, and when they compared, there was significant better radial alignment throughout the follow-up period. Internal fixation, Malhotra was 48%. Recovery was fastest for internal fixation and slowest for external fixator. But by 12 months, there was no meaningful difference in outcomes. So we can say if patient wants early recovery, early return to the function, then maybe plates are better than the cast. But there are chances of complications with tract infection, obviously with KY, external fixator. There are chances of CRPS, nerve lesions, rate of complication also depend upon the type of fixator used. Volar locking plates have highest complications, which are major, but these are basically less in number, but they have major complications. Non-invasive treatment has the least complications. Sometimes these patients have a high chance of CRPS. Stiffness becomes very common in these patients. Obviously, we all know the nerve compression may lead to RSD, but there's a big question mark. How much compression can lead to RSD? First. Second, in the world, basically, especially when I did my fellowship from Spain, there's a group of surgeons, Del Pinal et al. They believe it's a secondary complication. There's nothing like RSD. So we have to be taken care of. It can be because of malunion. And we have to have a very low threshold for CTS, please. Early mobilization, vitamin C, pain control, wallet, all these are techniques which can be employed for these patients. Especially the pain control in early part is very, very important. And we have to take care the patient does not develop any swelling. There are chances of major complications associated with plates such as flexor pollicis longus, adhesions, or tendon rupture, EPL. Patient can have carpal tunnel syndrome. When they have seen the carpal tunnel syndrome, 18.5% patients had of intersection carpal tunnel syndrome, and 25.8% with external fixator, 23.2% with pinning. So this is very, very important because it comes out to be around 20%. 1 of 5 patients may have carpal tunnel syndrome. So we need to have very less threshold for release of the carpal tunnel in these patients. And I preferably sometimes do with dual incision rather than a single incision, because once you use a single incision, there are always chances of damage to the superficial sensitive branch. So this is one thing. Use a double incision technique for CTS release when we use a distal radius fracture. There's always chance of refracture in these patients, even if you have treated and have. So we should not remove the plates in these patients. Basically, there's always chance of refracture, and have to take care of the osteoporosis. So all these complication rates, all this management, we have to discuss with the patient, because every technique has some disadvantages, every technique has some advantages. So there has to be a detailed discussion with the patient, and then we should take a decision basically. To conclude, I like to conclude basically closed techniques are still gold standard, and if we see this decade basically 2010 to 2020, then there has been literature, there has been results which has shown an equal outcome at 1 year, and but there's early recovery rates has been seen lately in this decade with ORIF. There's no consensus for the treatment of these fractures. Perhaps volar locking plates are equally good as they are in young individuals. So if patients want early recovery, they want to return to their function, they want to have an independent life, then ORIF can be considered in these patients. Thank you.
Thank you, Dr. Tahir, for such informative lecture on distal radial fractures. I think we can have few questions from the faculty or panelists on this.
Vijay?
Yes, Dr. Pradeep, please.
Very good talk, Dr. Tahir. I just want to ask one question to you. Like in Corey's distal radius in elderly, we really accept everything. But in volar Barton, very committed, patients are not ready for surgery. But the wrist goes subluxated, right? How you explain them? Fracture still unites, but with subluxation of the whole wrist. How you explain them, the deformity?
So this my talk was about the distal radius fracture elderly, and the most common fractures are dorsally displaced fractures. And these, if you see the results of different studies, they have excluded the shear fractures. So if the patient comes with a shear fracture, volar Barton, dorsal Barton, or the radial slide, this is more than 2 mm displaced, then this has to be operated. There is no indication of doing a conservative treatment these type of fractures.
So I want to share with you very badly distal radius comminuted fracture, volar Barton. Patient was not ready for surgery. She was 76. I explained very clearly, fracture may unite, but the full subluxation happened. She was very happy. No surgery, I'm okay. Now she's coming to me. I want the panelists, how they take it about these cases. The same thing. Any experience, Tahir? Like, not the Kohlis, I'm not discussing Kohlis. Volar Barton, committed, patient doesn't want surgery. We advise them sometime. We treat them the plaster. Functionally,
Yes,
how you feel how functionally you feel the patient will be inhibited in his routine life?
So actually, every patient is different. If we see these patients who come to us, if they're living in a joint family, so those patients tolerate it better. But those patients who have a independent lifestyle, then those patients are the candidate for surgery. The general patients that we see, I don't think they require surgery for that. And sometimes if they require surgery, a secondary surgery, then there are other options basically that can be used, such as radioscaffold unit fusion or that type of surgery. But these are for literature wise, these are important, but I have not done these surgeries for elderly individuals because most of them are satisfied with the outcome. They don't have that much of demand, physical demand. So it depends on discussion with the patient.
Thank you, Dr. Tahir. I think message is clear. If you find volar Barton, dorsal Barton in any age group, I think we should convince them for surgery. I think this is the message. I think Dr. Tahir, you want to displaced volar Barton or dorsal
Dr.
Barton.
Vijay,
I think let us move over to the.
Dr. Vijay, my question is: considering we advise a surgery, right, and patients not willing, what we are expecting from those cases? This is the only question to Dr. Kotwal or any other faculty can answer. What we are expecting in those cases, considering they're not ready for it, we are treated conservative. That is all.
See, if you have already, as you said, you have explained to the patient and given the option, the best option, so to say, and if the patient is willing, well and good. If he doesn't, is not ready for surgery, then he kind of is responsible for that. You must actually record it properly somewhere that the patient is not ready. And then another question is what best can be done to correct that volar translocation of the carpals because in a volar Barton. And you, of course, have said you are treating them with a cast. But maybe since I have not seen the X-ray, but maybe you could perhaps also talk about like what Tahir said, maybe with fixation with K-wires or with an X-fix or something for some time, at least so that some restoration of the anatomy around the radius or the rest can be restored. But yes, the patient, it must be explained the pros and cons. And then, because then the complications would be that because of the volar translocation of the carpals, there is likely to be mid-carpal instability and all those things, restriction of movements and everything is likely to happen. Although the age is that much, I know, but still, theoretically speaking, these are the problems of a malunited distal radius fracture.
Thank you, sir. Thank you.
Thank you, Dr. Tahir. Now I invite Dr. Amit Sharma for his talk on fracture neck of femur in elderly current perspectives. Dr. Amit.
Thank you, Vijay. I'll just share my screen. Hello. So I'm going to talk about hip fractures and that also in elderly. So a very hot topic nowadays, but it's a very vast topic that was given to me. But before I start, I'll just tell you where I work. I work in Newton Dunstable Hospital, which has just taken over another hospital and we have become a bigger trust. We call the Bedford Hospital Trust now. So that's my city. It's made up of a vast majority of immigrants. It's a nice place to work. We are called the Hatters because hats were made here in the olden days. That's my hospital. But this hospital, next to the hospital, there's a big motorway. That's the aorta of England. That's the main motorway. So we get a lot of fractures and trauma, and we are kept pretty busy because of that. But otherwise, it's a nice place to live, nice countryside. And we carry on. We are the NHS warrior, me and my kids. You might hear them in the background practicing their warrior skills at each other. So we're talking about the hip fractures. Everybody knows that the global number of hip fractures is increasing. There used to be increasing epidemic. They were controlled a bit earlier on in about a decade back when osteoporotic treatments came in. But again, they're on the increase. The typical patient usually in our setup is in 80s, and 2/3 of them are females. Importantly, there's a large amount of mortality as well as mobility. Mortality and morbidity associated with these fractures. And as orthopedic surgeons, we would like to treat all of them in the operation theaters, but unfortunately not. This is not a fracture. This is not a thing that we can treat in the operation theater. So if we are talking about hip fractures and we are trying to treat them, we need to treat them differently. And that's why I'm going to take you through a journey of the patient through a hospital. We deal with a lot of these fractures, and the way we have improved their outcome is through evidence-based practice that we have implemented in our hospital. And also there are some places where I'm recommending best practices where evidence is controversial or incomplete. But what I will be talking about will be based on expert consensus. So our interventions usually start from the A&E when the patient comes in. It's been shown that protocol-driven fast-track admissions really help for the patients. So these protocols and these pathways need to be made so the patients are identified early. It helps if the patient is in the main ward within 4 hours. It's been shown to improve their final outcomes. If there is problem with diagnosing, nowadays, if the plain X-rays are not able to find the fracture, MRI is now the gold standard. But if MRI is not available within 24 hours or is contraindicated, then a CT is the next advisable mode of investigation. Now, of course, it's a fracture, and fracture means orthopedicians need to treat it, but not this fragility hip fracture. It's been increasingly shown that patients of fragility hip fracture need to be treated by a multidisciplinary team that is led by orthogenetician. I know it's difficult for us to sort of accept that, but it's like asking the ophthalmologist that they need to admit their cataracts under the gynecologist, but no, these fractures need to be treated by orthogeneticians. Also, it's been shown throughout, at least in England and I'm sure in Scotland, that multidisciplinary hip fracture management groups, they really help in improve the outcomes more than anything else, anything we can do in theaters. So these groups are made up of everybody who will be contributing to the care of the patient. It depends on the hospital and the setup, but that would essentially mean surgeons, anesthetists, orthogeneticians, physios, and occupational therapists. They need to move and meet, communicate with each other, and get all the pathways made so that the treatments are run smoothly, and they need to assess if those treatments are going on smoothly. So in our hospital and many hospitals, we have found that dedicated hip fracture wards have really changed the outcomes of the patient, especially because the staff is trained to deal with that kind of patients, and they know all the pathways. Also, moving the elderly patients from one part to the other causes delirium, and that is prevented by this dedicated wards. The big six that is emphasized in the ward is pain relief, delirium screening, blood investigation, fluid therapy, pressure area inspection, very simple things. But believe me, these are the things that make difference for these patients. Pain relief is the paramount important thing here. It's been shown that if pain relief need to be given within 30 minutes of admission, and you need to assess this every hour till it settles down. NSAIDs are not recommended for obvious reasons. Opioids should be limited in their use as much as we can. Nerve blocks are what we are recommending more and more. The use of fascial lacquer block has increased, and in our hospital, it is given to almost everybody. It can be repeated within 12 hours, and it's a big success. But of course, we don't use it as a substitute for early surgery, because surgery is the best painkiller. Now, time for surgery. It's been shown that if you operate within 48 hours, there is a lot of difference in the morbidity as well as difference in mortality also of these fractures. Preferably, they should be operated within 24 hours. Of course, it all depends on how much facilities we have in the hospital. Now, anesthetists, we all know, they have the main influence in getting the patient to the theaters. They are the main role bearers for the timing. So preoperative assessment by them is very important, not just before the surgery. They need to be seen as soon as possible so that they can plan and pre-optimize the patient. We identify and treat, but do not delay the surgery. These are the various things. So the rule of law is that what we follow, of course, is that anything that is reversible and which is going to influence the per-op management of the patient needs to be reversed. But if something that cannot be optimized or reversed, we go ahead with the surgery. The usual things that make us wait is anemia, uncontrolled diabetes, volume depletion. If there is chest infection or chronic exacerbation of infections, we start the treatment immediately. We are very good with it. Anticoagulation, increasingly in the elderly population, we are finding various kind of situations with the anticoagulants. Over the course of years, we have come to conclusion that mostly nothing stops us or delays our surgery. We reverse the warfarin the moment the patient comes to us. We have got pathways and that have shown the best results. Even with other anticoagulants, unless their renal function is very bad, we do not wait for surgery and we go ahead. Of course, we expect a little more bleeding and we balance that. Anesthesia, more of intraoperative regional blocks are recommended, and spinal anesthesia is deemed safer, though we still have anesthetists who go for general anesthesia. We come across many patients who are too sick to operate. This is the usual term we used to hear when we were canceling a lot of patients with hip fractures. But even in terminally ill patients, we should consider or discuss the hip fracture operations with the patient, because they are the best pain relief. So they act as a good palliative care for the patients. And of course, we have to take in consideration the patient's priorities for rehabilitation and end-of-life care, what they want. And we have our cardiac and medical doctors who help us out. Now we come to the juicy part for the orthopedic surgeons. Yeah, surgical dilemmas. I'm sure all of us are aware of them. I'll just walk you through a few of them. Undisplaced fractures presenting to us. The dilemma is where to fix or trial without fixation. Many studies have been done, and it's been shown that almost up to 50% of them subsequently displace. And increasingly, especially in our hospital, current practice is that we internally fix all of them. How do you fix them? DHS or multiple screw? DHS have shown better outcomes in multiple studies. Though if you have to use multiple screws, then the reverse triangle is the best configuration. Intracapsular fractures, how do we treat them in the young patients? Irrespective of displacement, we fix them. In elderly patients, arthroplasty is the recommended treatment. So very rarely we go for fixation. So the age here is of importance, but again, the question is, who is young? I get like 70 years old patients who are any day better in physical attributes than me. I'm sure they could beat me in any of the games. So it's difficult to quantify the age, but yes, essentially that is what we do. Then again, if we are going to do arthroplasty, what kind? Hemiarthoplasty or total hip replacement? We've got multiple guidelines, multiple studies have been done. It's been shown that total hip replacement gives much better functional outcome. And they're recommended for people who are independently mobile and have intact cognition and are medically fit for the surgery. So you would see that importantly, the age factor is absent here. So mobility and cognition is important. Of course, hemiarthroplasty is easier to do and less time consuming and probably better for more sick patients. So then the debate comes whether we do it cemented or uncemented. Cement has shown embolization, and we've lost many patients, which have been blamed to the cement embolization. But uncemented stems, on the other hand, have caused periprosthetic fractures and have got inferior functional outcome. They have thigh pains and subsidence. Well, if we decide to do total hip, again, there are dilemmas there. Do we cement? Do we do uncemented or hybrid? Well, the jury's out for that. But in fracture setup, maybe doing cemented is a safer option because the bones are already osteoporotic. I'm sure many of the orthopedic surgeons will not agree with that. Well, head size, what do we use? There is historically increased rate of dislocations in total hip replacements. So, but the literature favors, it has been shown that size 32 is the standard, but there is no increased or better dislocation rate after the size of 36. So the recommended is 32, or you can use 28 or 36 sizes, but other sizes are not recommended. Then do we use dual mobility hips or do you use the conventional type? We're going to touch that again. I'm talking about the hip sizes. The bigger hip sizes have caused L-wall and ALTR lesions, and we are all aware of that. They've all got bad press. Patients are more aware of them than us. Dual mobility, though they are good with dislocations, but they've again got their own problems. So their use in primary fracture treatments is limited at the moment. They're in our hospital, at least, they are limited to revision surgeries or dislocated hips mainly. Approach, that's another bag of worm, but it's been shown in many studies that anterolateral approach is the favorable approach, especially if you're doing hemiarthroplasty when we are treating the neck of femurs. Now we come to the extracapsular fractures. It's got its own bag of dilemmas. Extramedullary implants, that is the sliding hip or dynamic hip screws. We offer them for AO classification A1 and A2, but in other simple term, stable fractures, they can go for DHS, whereas intramedullary nail has been shown to be advantageous in situations where there is compromised medial calca, large posterior medial fragment, or there is extension to subtrochanteric areas, reverse obliquity fractures, and transtrochanteric fractures. I'll show you a picture of all of them. These are the villains. I'm sure
Dr. Amit,
yes.
Can you hear me? I think extracapsular fractures, Dr. Shiv Shankar is going to speak on that. If you are, okay. I hope you are not taking that part also. Yeah.
No. My slide for extracapsular is finished. Okay. I was going to touch on the nail nails. That we just use long nails. So there are intraoperative measures we can take to improve the morbidity and mortality in the patients. So we use tranexamic acid that is shown to reduce bleeding both per and post-op. We give regional anesthesia again afterwards. And here you can see us using the pain buster ball. We use continuous infusions into the fascia iliaca for 24 hours after the patient has been operated on. They've shown enormous benefit in our patients. The use of morphine-based and codeine-based products has decreased quite a lot because of that, and better mobility afterwards. When to weight bear. The main gist of the surgery is that the patient should be able to weight bear straight off the table. So the fixation should be that. Offer physiotherapy within 24 hours, unless surgically and medically contraindicated. Now, post-operatively, the journey continues. We need to have cognitive assessment, nutritional assessment, and fall prevention assessment, either by a specialist or by a medical doctor. Again, physiotherapy, reduce risk of bed-bound complications. So one of the important factors is the patient should be up and about and back to the pre-fall mobility level as soon as possible. And every patient needs to be assessed for fragility fracture risk and should be treated for osteoporosis if clinically appropriate. And last of all, data collection is important. I'm telling it from our own experience. UK has a national hip fracture database that has been started a few years back, and it has been instrumental in enormous changes in our practice for hip fracture management. Again, it can be started to improve your local or national processes. Thank you for hearing me out. I'm finished.
Thank you, Amit. So nice of you. Such a wonderful presentation. I think we'll have question after the intertrochanteric, because obviously there are going to be some questions, and after Inder's talk. So we are getting late, just 30-35 minutes late. So I think we switch over to Dr. Shivshankar, B. Shivshankar sir's talk on percutaneous fractures. Thank you.
Good evening, everybody. Let me share the slide. Sorry, because the icon is not showing. All of you, can you see my slide?
Yes, sir, it's visible, sir.
Yes, sir. Yes.
Okay,
yes,
fine.
Sir. You're audible.
Okay. At the outset, I would like to thank Delhi Orthopedic Association for having me for the third time in their midterm meet. I'll be talking about osteoporotic fragility fractures in proximal femurs issue to avoid pitfalls. I'm probably the only non-professor speaker today, because in the midst of all the luminary of professors, I'll be talking as a private practitioner with some experience of treating these fractures. When we see an elderly lady of 85 years with such a fracture, what are the things which comes to our mind? Whether the fracture is stable or unstable, any further investigation is needed, like a 3D CT or a CT scan. What are the implants one has to use, DHS implant or IM implant or replacement? Any other implants to be ready, like a trochanteric buttress plate, wire, CC screw? Patient associated condition, whether it is fit for surgery, so many things comes to our mind. First and foremost, we have to classify the fracture as stable and unstable. If the lesser trochanter is intact, it is stable. If it is broken, stable. Lateral wall intact, it is stable. Lateral wall broken, it is unstable. Implant for intertrochanteric fracture is still debatable. Depends on surgeon, setup, familiarity, and the implant's availability. Definitely not scientific, but playing a major role is socio-economic status of the patient, elderly, non-productive patient, poor insurance coverage. All those things also play a role. We have both DHS and intramedullary implant, but what is more important is knowing the principles behind this implant. An expert can get good results out of both these implants. So you have to tackle the posteromedial fragment, tackle the lateral wall issues, maintain good result, good reduction till the bone unites. Here is an example of a 75-year lady with an intertrochanteric fracture with posterior wall practically missing. I have treated with the intramedullary implant. You can see that the posterior wall is missing there. But in due course of time, I don't know why it is not doing. There is some problem. Yeah, this is the immediate post-operative X-ray. This is at 3 months, and you can see that fracture has healed. I am sorry, because of the video, it has totally stopped. I had to restart my presentation. I'll just take a minute. That time, if there is any questions, Dr. Anil Sharma can answer that question.
Yeah, I think Amit, we can have one question to Amit. Amit, you're there?
Yeah, I'm here. I'm just trying to start my video.
Yeah. Actually, I have one question regarding MRI for neck femur occult hip fracture. So, how many times you do MR to detect occult hip fractures?
It's become our policy now in our hospital. So maybe once in a month we get a patient where we can't sort of diagnose based on clinical examination and plain X-rays. So our protocol is to get an MRI scan first.
Okay.
Yes, Dr.
And regarding total hip and bipolar, like what exactly is your indication of doing a total hip replacement in geriatric neck of femur fracture? Like any age group, or you look at the activity criteria? What exactly is the criteria?
Activity is the main thing. We've been guided. NICE is our centralized place where all the pathways are made. They have guided us also for offering total hip for any patient who is able to mobilize very well. So age is not a criteria. Of course, cognitive, if they're intact cognitively, that is very important. And of course, medically, they should be fit for anesthesia and big surgery.
Okay. Okay, now the presentation is ready. Thank you, Dr.
Yes. Sorry for this interruption, because I had kept this presentation open for a quite long time. That was the reason probably. You're with me, no? Yeah. This is at 3 months. Can somebody say, are you able to hear me? Hello?
Yes. Go ahead, sir. You are audible, sir. Yes, sir.
Okay. This is at 3 months. You can see that the posterior wall, which was missing initially, is formed totally. This is at 8 months. Fractures united without any problem in a 75-year-old lady. This is another person, a 70 to 75-year-old person. 4 months, you can see the function beautifully, all functions returned. 75 lady, again treated with a PFN long time back. This is in 2009, I have operated. See the positive medial cortical support, and at 14 months, beautiful restoration. See the screws are not backed out because I compacted the fracture adequately on the initial first day itself. Again, fracture 5 years back beautifully has healed, and the fresh fracture has been treated again in a 70-year-old lady. A 87-year-old lady, again, fracture has been stabilized with a intramedullary implant. 85-year lady, again, you can see that the big canal. So getting that out with a Steinman pin manipulation and getting the reduction, medial and anterior reduction properly, implant like this definitely will add the stability of the fixation and good surgical outcome. 83-year-old male, again treated with a intertrochanteric, high subtrochanteric fracture. Again, see the beautiful reduction, positive medial cortical support and anterior reduction, which ends in a good result. This is a 45-year-old alcoholic. So osteoporotic fracture, it doesn't mean the patient is elderly, 75 plus or 80 plus. So even a young patient, 45-year-old person, can have an osteoporotic fracture due to nutritional deficiency. I will talk about this back end of the screw little later. Friends, age is just one of the criteria. If you are able to reduce and fix a fracture well, osteosynthesis should be the first line of our treatment. By chance, if my osteosynthesis fails, because we have almost 9 to 10% of failure of osteosynthesis even in the best hands. Then we have good replacement surgeons like Professor Rajesh Malhotra who can take over and treat this patient. Here is an example of a intertrochanteric fractures. One of my friends shared on my WhatsApp, and he has treated in this fashion. When you analyze this fracture, there is varus reduction, and you can see that the beak is going inside the medullary canal, negative cortical support, superior opening of the fracture because the nail has been shoveled to the fracture site without making a proper canal for the nail. Superior screw longer, that will lead to Z effect because the load is taken mainly by the superior screw, especially with this varus reduction. Beak of the proximal fragment entering into the distal canal. It's not a Diamond Houston type of stable osteotomy with the intramedullary implant. It is definitely varus. Friends, newer technique has long learning curve. How to minimize these pitfalls is the part of my talk today. If you are doing this surgery regularly, you should have your own set and you should get used to all the implants instruments very properly instead of trying newer set every now and then. You should also know what are the factors you should keep in mind to get the best result out of any of the implant. Implant is not the one which is important, it is the surgeon who is important. Implant is just a tool to fix the fracture. Outcome of any surgery, we all know that it depends upon the reduction and the surgical skills of the operating surgeon. They cannot be compensated by the poor surgical skills. You can use the best of the implant, but if the surgery is done not properly, it's not good. It's like a good implant or a implant is like a business class or first class travel. And I can compare the Atmanirbhar Indian implants like economy class. You should know that the time required to reach your destination is the same. Just because you are in a business class, that doesn't mean that you reach your destination quickly. Similarly, just because you are using a costly imported implant, it doesn't mean that the fracture will heal earlier. It's only the life of the surgeon, like the person traveling in business class, his comforts are better. Similarly, with good set available, our comfort of operating surgeons are definitely better. This is a very busy slide. So what are the factors which influence the successful outcome? If you understand these 10 points clearly, then definitely you will be avoiding pitfalls during the surgery. I will not go through this slide, but I will take one after the other everything. First and foremost is good implant from a good company. There are poor substitute, thinner nails, thinner proximal end. As you all know, interlocking in a proximal femoral nail is done at far away from the tip to avoid peri-implant fracture. So the gun drill nail with a good 316 LVM metal one should use, not a poor substitute which are very cheap available in the market. Second foremost important is good anti-reduction. See on the left, anti-reduction is not at all there. With a Steinmann pin, I am getting it reduced and see the end result. This is very, very important. Third is medial reduction. Medial reduction should be neutral or a positive medial cortical support. So what is this neutral? This is negative. Beak going into the shaft is negative reduction. Beak touching the shaft is neutral reduction. Beak going out into valgus is positive. We should try to achieve positive medial cortical support. And also you can achieve a neutral reduction with a valgus, but never ever accept beak inside in the medullary canal, which is varus. The position of the screw is also very, very important. The AP should be in the center or slightly inferior to the center, and in the lateral, it should be in the center or slightly posterior to the center. These are the point number 5 and 6, which are very important. Point number 7 is tip of the cervical screw should be as subchondral as possible. That is, the apex distance should be less than 25 in both AP and lateral. For me, instead of apex distance, Calcar TAD is more important for me. What is that Calcar TAD? Normally, if you measure the distance from the fovea centralis to the that is both AP and lateral put together is the TAD. But if my cervical screw is very, very inferior, if I measure in this case, TAD will be definitely more than 25, both in AP and lateral put together. So what we should measure is, instead of measuring the distance from fovea centralis, measure the distance from subchondral bone in the same line of the screw. So this is called as calcar TAD. Your calcar TAD should be less than 10 millimeter, both in AP and lateral picture. The fracture should be well compressed, as you can see, so that the screw will not back out. Back out screw toggling outside is one of the main reasons for failures in these osteoporotic fractures. Next is back end of the screw should be slightly out, especially in the headless screws like PFN A2, pigeon nail, all these cases, where you can see that they can slide out slightly to allow collapse to happen. If the back end of the screw is inside the medullary canal, it cannot back out and penetration chances are very, very high. So this is an example which I showed earlier. You can see that I have done the mistake of keeping the back end of the screw inside the medullary canal. That can cause, due course of time, some problem. Last but not the least, nail at the entry should be slightly out. There should be a support at the cortical bone here. If the nail is inside, it again like a DHS in a reverse oblique fashion, the nail can slide medially and cause havoc in these cases. So these are some of the points which are very, very useful. I asked Dr. Vijay Sharma how much time I have got, and he said that 10 to 12 minutes for the talk. Since I know that we are taking little more time, let me give some idea more about this talk. I was supposed to stop here. I have added at least neatly one of the commonest mistake people do, that is the entry site. What is the entry site for PFN? Is it dictated by the manufacturer, or it has to be dictated by the surgeon? 5 to 7 degree bend is given to the entry site, then if it can help the surgeon to take the entry from the tip of the trochanter, I will ask, why don't you give 90-degree bend to the tip and ask them make the entry from the lateral of the GT? Because I feel that problem of varus as well as superior screw placement in the head leading to cut out easily are because of shifting the entry from piriformis fossa or medial to the trochanter to the lateral aspect. This is a PFN with a 5-degree bend. So entry, instead of being from the piriformis fossa or medial to the trochanter, we have shifted it by 5 to 7 degree laterally. But you can see that this is my question. Why don't you give a 90-degree bend like this and make the entry instead of from the tip of the trochanter? Why can't you make it like this? So the same problem happens. You cannot put a entry nail from that side. Similarly, it's always difficult for you to put a entry if you take from the tip of the trochanter, especially in Indian bones. The entry for any of the intramedullary implant is medial to the tip of the trochanter, even for all trochanteric nails, which we normally refer to as piriformis. This is a misnomer, but it's always we refer to as piriformis entry. My entry for all fractures of the femur, whether it is intratrochanteric or subtrochanteric or shaft, it's medial to the tip of the trochanter or misnomer piriformis fossa. For any femur nailing, from femur nail to recon nail, entry should be from medial to the tip of the trochanter in the AP and center of the leg in the lateral or slightly posterior for the shaft fractures to avoid stress, to avoid complications like iatrogenic fracture, varus malreduction, and suboptimal neck position of the neck screws. This is the piriformis fossa. That's where that is not the exact entry, and that's not the exact place where the piriformis muscle is also attached. This picture depicts where I want to take the entry. It's not the tip of the trochanter, it's not the piriformis fossa, but it is much more medial, where I have marked with the pink. That is my entry, which is in the center. You can see that the screw position will be very good. In Caucasians like Europeans and Americans, the morphology of femur is slightly different. When you take the tip of the trochanter entry, you can see that the line can enter in line with the medullary canal. That's why they will advocate to use that entry, and will not cause shattering of the lateral wall. But if you take the X-ray of some Asians or Indians, you can see that tip of the trochanter is more in line with the medial part of the proximal femur. So the piriformis are medial to tip of the trochanter entry only can allow you your nail to be passed into the medullary canal. And if you take the tip of the trochanter entry, lateral wall bursting is very, very high, or the proximal fragment going to varus is very, very high. This is a case I have operated myself, subtrochanteric fracture. I've taken the tip of the trochanter entry sometime back in 2006, and I have done the reaming, and even the flexible guide wires have gone beautifully. When I pass the nail, you can see I have shattered the medial fragment, because nail cannot bend like the flexible guide wire. It will only cause iatrogenic fracture if you take the tip of the trochanter entry. So I always advocate, take the entry in line with the medullary canal, then you can pass the nail easily. Also in a narrow medullary canal, you can pass a thicker nail. This picture denotes the tip of the trochanter entry is taken. You can see that the screw position is also not proper, and also distally, the nail is not going to the middle canal. When the entry is more medially, screw position is also good, as well as the nail is also entering into the distal medullary canal properly. This is the bone model for Indian patient, and as well as the nail is manufactured in India. Here I have used a PFN. Just because it's a PFN, I have not taken the tip of the trochanter entry. You can see it's much more medial, and see the position of the neck screw. So just because it's PFN, it doesn't mean that I had to take the tip of the trochanter entry. This was a demonstration case surgery I did at Sancheti Hospital during their trauma con. You can see again, such a nail has been passed in a medullary canal. 11 millimeter nail I was able to pass only because my entry is in line with the medullary canal. Here, this is an example which depicts when we take the entry medial to the tip of the trochanter. By the time we finish reaming, we have reamed more laterally. That will be in line with the medullary canal, in line with the tip of the trochanter. If we take the initial entry itself for the tip of the trochanter, the bone is more softer on the lateral aspect. We end up reaming more on the lateral side. So this lateralization of the entry side is the cause for varus reduction. Especially if there is a fracture at the entry side, definitely take the entry more on the neck like this. This is what the entry I have taken, and this is the end result in the same patient. Now you can see the beautiful position of the nail as well as the neck screw, and this is at the end of the treatment. The fracture has consolidated very well. What happens if the entry is taken over the tip of the trochanter? These are the last few slides. Beautifully reduced fracture on a table, but when the entry is made, you can see that the fracture is still reduced very well, not a problem. Again, the guide wire is passed through the related owl, is beautifully reduced. Now you can see what is happening. When the nail has been passed, the proximal fragment has gone into varus. I'll go back one slide. Beautifully reduced fracture till the time guide wire has passed. When the nail is passed, you can see the proximal fragment goes into varus. That is the reason why I tell you should take the entry in line with the medullary canal, not from the tip of the trochanter. This is the mal reduction. With such a gap, the chances of uniting in the subchondral area is very, very less. What happens if you take the entry from the tip of the trochanter? You can see when the proximal entering owl is passed, many a time the lateral wall is under threat. Many a time we end up reaming more of that because the bone is softer on that side. So you should avoid reaming by taking a entry very, very lateral. The final slide to show you all the entry site of the trochanter entry, lateral to the tip of the trochanter entry, because the PFN-A2 has come out with lateral to the tip of the trochanter entry. Variformis fossa entry, which is mainly for shaft fractures, medial to the tip of the trochanter entry. What I will advocate for all these fractures. Thank you very much. Thank you for your invitation as well as the time allotted for me. Thank you.
Thank you, sir, for this excellent presentation. I think we'll have questions at the end of next lecture, I think. So over to Inder. I think this is going to be very important lecture because how they manage the patients after, managing the fracture, so how the NHS works on their fragility fracture services. So over to Inder.
Yeah, can you hear me?
Yes.
Yes, sir, you are audible, sir, please.
Okay, so thank you very much, Vijay, and everybody involved with the DOA for giving this opportunity to present. So I'm going to talk about the role of fracture liaison service and what is our model and how we practice it. So that is the, okay, so what I'm going to say is what is the concept, why should we use it, what are the standards which are there from various societies in the UK, and how do we measure up to that? How does it work in practice? What are the steps that we do? And there's a timeline as well, again, with the standards which have been given to us, which we should try and adhere to them. So as you all know, and has been brought out with various talks, that fragility fractures are common, but has severe consequences. So as you know, it is 10 to 25% mortality, almost 50% are unable to walk independently after a hip fracture. And therefore there's a substantial decline from their prior level of function. There is other problems like depression, chronic pain, but the most important, where the role of the fracture liaison service comes, is to reduce the risk of subsequent fractures. So it's like a secondary prevention technique. So as we said, it's common. 1 in 2 women and 1 in 5 men will break a bone after the age of 50, as you can see. It's very costly as well. So as you can see, the hip fracture itself costs about 1.1 billion pounds in the UK, and it is life-changing to the individual. So that's as it leads to a lot of these consequences. So what are the major risks of fractures? First of all, and the most important, is prior fragility fracture. So if we can identify the group of people at that point, then we can reduce the risk of subsequent fractures, and that is where the primary role of the fracture liaison service is. Obviously, there are other risk factors like increased age, low mineral density, low body weight, family history of osteoporotic fracture, things like steroid use and smoking. So as we all know, it is not just the bone quality which is important. There are other things that have an impact on susceptibility of secondary fractures. So there is environmental fractures, age itself, which causes increased falls. And then what's the impact of the fall depends upon where the patient falls, what's the energy absorption, whether there are any external protection devices, and the bone quality, the bone shape and architecture has an effect. So it's a combined effect of not just the bone strength, but the incidence of falls and the fall impact. And each of these can be affected by the fracture liaison service and effectively reducing the fracture risk. So obviously we have guidelines, as you all know. So first guidelines is from the BOST regarding fragility fractures, that all patients with fragility fractures, basically what is a fragility fracture? All patients who sustain a major trauma with a frailty score of 5 or more are fragility fractures, and all of them need orthopedic care. But in addition to that, as Amit had said in his talk, comprehensive geriatric assessment is very important because that plays a multidisciplinary role. So what does the fracture liaison service does? It is again a multifactorial falls risk and assessment, and it is a referral to the falls prevention service. So they look at what's the reason for the fall, how can we reduce it. They also do a bone health review. So they do a bone mineral density if indicated, and investigate it and prescribe any necessary medication. They also do a nutritional assessment to see if there are other things that can be corrected. So the purpose of this service is to provide secondary prevention for fragility fractures. All patients over the age of 50 years who have a fragility fracture are taken over by this service. They identify patients either in the secondary care, which are the hospitals, and also in the primary care, that patients can be referred through their general practitioner as well. And they assess the risk and they provide advice and therapy. So this, in a nutshell, is the role of the liaison service. So what are the standards that we need to measure up to? So all patients, it should be available to all hospital patients who provide definitive fracture care. So in effect, all hospitals should have the service. Again, as we said, we need to delegate control to others. So it should be led by a consultant physician, generally a rheumatologist, sometimes with a general practitioner who have appropriate training and expertise in osteoporosis management. All patients should have multifactorial bone health assessment within the 3 months of their primary fracture, and they should have access to DEXA scanning to find their bone mineral density. And there should be a linked metabolic bone service. So if somebody needs, in addition to standard osteoporosis service, further metabolic bone disease, then it should be linked and need to be referred by that. All patients should receive written advice regarding what's the nature of the fragility fracture, what is the bone health and the lifestyle, and how things can be improved. And obviously there should be a system in place to review the compliance with treatment and whether this actually is really working or not. So how does it work in practice? Well, first step is to identify. As we said, all patients over 50 years who have sustained a fragility fracture need to be identified. This is generally undertaken by a fracture liaison service coordinator, and it's typically a nurse or a senior nurse specialist. And how does she do it? She looks at the IT system. Most of our patients have electronic patient records to look at the IT system of who have had fragility fractures in the past week or month. They also come into our orthopedic ward rounds and trauma team meetings in the morning. And they attend fracture clinics for patients who are not admitted, so they can capture all of them. So that's how they identify the target individual. And then the next step would be to investigate. So they assess the risk to the fragility fractures and the risk of falls and what are the underlying causes. So I'm sure you're aware, but there is a fracture risk assessment scores. It's generally the FRAC score, which is the most commonly used. Some hospitals use the Q fracture score as well, which helps to assess what's the risk of getting a secondary fracture. And again, it also decides whether you need a DEXA scan or not. In addition to that, an independent falls risk assessment for all patients over 65 is done. And on the basis of that, laboratory and imaging investigations are done to find any secondary causes of osteoporosis which can be corrected. And then once that is done, then the information is given to obviously the patient and the support are offered. Lifestyle changes are also done, like improving nutrition, improving exercise, putting in effect bone protection measures. Drug treatment options are given for osteoporosis, including obviously the risks and the information on benefits and side effects, and reduce the false risks. So information is provided to the patient and the GPs. An intervention is given depending on what is found, how you can reduce the risk. People who are osteoporotic are started on osteoporotic treatments. People who are at risk of falling are referred to falls prevention. And people who have recommended intervention to the risk are reassessed. So that's very important as well, that the patients are reassessed at 1 year, that whether all these interventions have taken place or not, whether they have made a difference, whether we need to follow up DEXA scanning. So generally in the UK, if you are found to be osteoporotic, generic oral bisphosphonate would be recommended as the first line. If the patient is not compliant or it's not working for them, then sometimes second and third line injectable bisphosphonate treatment can be done. There are other options available for patients who are allergic or do not respond to them at all. And treatment review is performed at 5 years for patients who are on standard bisphosphonate treatments, and after 3 years for patients who are on zoledronic acid, whether we need to give a break in the bisphosphonates, as I'm sure you've been aware that bisphosphonates can cause atypical fractures. Vitamin D and calcium, again, are recommended concurrently in most patients. And generally in the UK, it is recommended to take 700 to 1,200 milligrams of calcium. And in patients who are postmenopausal or men who are more than 50 years of age, 800 international units of vitamin D3 is advised. Obviously, they have their vitamin D measurements, and if they are less, then increased doses can be advised. So then what happens with this? All the advice that has been provided goes to the patient as well as to the general practitioner, so that the whole service is integrated with the wider healthcare system, so that there is ensured that further ongoing referrals and long-term support can be provided. So in addition to that, the quality of the service has to be ensured as well, which is done through a continuous improvement and regular audits. In addition, similar to like the National Hip Fracture Database, there is a fracture liaison service database as well in England and Wales, which where nationally the audit is done of how much percentage of patients are getting the service, how effective they are, etc., and what can be done to improve it. So they look at the peer review and patient and carer experiences as well. So that in a nutshell is how fracture liaison service works in most of our hospitals. So there is a timeline which has been provided, again, which we need to adhere to. So the day one will be when the patient is identified who has broken his bone and is known to have a fragility fracture. Within 12 weeks, the patient should be assessed by the fracture liaison service, and if needed, they need to have a DEXA scan. And by 16 weeks from the primary fracture, they should have started the treatment with osteoporosis treatment, as well as a further treatment for reducing the falls and bone strengthening exercises, etc. is done. Then at 52 weeks, that is 1 year, the patients are contacted again to see how they are responding to the drug treatment, whether they are having any problems, whether the compliance is good. And further follow-up is recommended at 3 to 5 years, whether we need to take a treatment break, repeat DEXA as required or not. So this is in a very broad nutshell of why the fracture liaison service is important, how it is done, what are the standards that we measure up to, and how we try and improve it for the future. So that's very small and brief presentation. Thank you.
Thank you, Inder. Such an outstanding presentation, and having this mysterious area clarified, because in India, I think very less number of hospitals there's nothing as such a national policy for for fragility fracture liaison services. So now, Dr. Manish, how much time we have for questions, because we are almost 1 hour late, and there are 3 cases also, if you allow. Otherwise, we can leave it for the 19th.
I have a question to Dr. Inder. The first part of the question is, do you use estrogen for female osteoporosis? One part of the question. Second is, since you are starting fragility fracture treatment by about 16 weeks after the fracture, meantime, are you giving for any of the fracture teriparatide injection or something else during this period?
So first of all, about estrogen, again, we don't do it routinely for all patients. The patients are assessed, and if most of them will be postmenopausal. So they are assessed by the osteoporosis service, but as far as my understanding goes, most of them don't routinely get estrogen treatment. Second part regarding the starting of treatment, the target is by 16 weeks, they all should be on osteoporosis treatment. A lot of them will already be, because they are already osteoporotic, but they may or may not be. But we don't routinely use any teriparatide or parathyroid hormones, etc. for fracture treatment. I don't know what's the evidence for that, but at least in the UK, there is no standard practice of using them.
Thank you.
Any questions for Dr. Shiva Shankar, sir?
Can I ask a question?
Okay, Dr. Sharad, please. Dr. Sharad, yes.
Dr. Inder, these FSL services, FLS services are provided by NHS, I believe, is it?
Yes.
The cost must be borne by the government, the manpower and the infrastructure. In India, most of the 80% of the healthcare is with the private sector. So, do you think this kind of a service we implemented in India?
Well, I know practically it is difficult in India, and the setup is very different. But what I wanted to present is that what's the utility of it, and it's certainly very useful because it's like something about prevention. It's like, I know people and healthcare are not investing that much into prevention, but this is like preventing secondary fractures, which most secondary care clinicians are not very much interested in. But if the budget, as you're saying, is less, if we invest initially, then you save later because the cost of treating them is much more. And I know this is not something for as a private practitioner you would be interested in, but I think as a government and planning, they are the ones who should try and implement this. And I'm not sure how best it is for the private healthcare.
Very true.
Dr.
Vijay, can I ask?
You want to ask something? Yeah, Dr. Harmesh, yes.
Yeah. So this question is to primarily Dr. Amit Sharma, or anybody else can answer me. If the patient is a high-risk patient for pulmonary embolism or DVT and is on Clexane, then what is the role of tranexamic acid? Is it counteracting, or it can safely be used in those patients also, where we are worried about DVT and pulmonary embolism?
Shall I answer?
Yeah, Amit, you can.
Yes, Amit, you are there.
Yeah, I mean, that's a question, a very valid question comes across, but tranexamic acid hasn't been shown to increase coagulability in any circumstances, but there is still not definite research to sort of disprove it. So in patients who are like in hypercoagulability states, there we don't use it. So
okay. Secondly, you said in hemiarthroplasty, you will rather prefer an anterolateral approach. Any specific reason for that?
The anterolateral approach in many studies has been shown to have less dislocation rates. Of course, it's dependent on the people who are doing it. It's a controversial thing, but in most of the studies, posterior approaches and other approaches have come equal to anterolateral in dislocation, but never superior. So if the studies, they would either show that anterolateral is better or equal. So it's never been that it's not or it's worse. So that's why it's been taken as a policy decision that for at least when we're doing hemis, we do it anterolateral.
Yeah, I have one question for Dr. Inder. Inder, like you work in a university hospital, I think things are different at your place. DEXA is there, all investigations are there. But suppose because a lot of patients, they come to district hospitals and so they are referred to you for these services, or they have got their own system, own fragility fracture coordinators and all that. In all the hospitals, they have a lot of fragility fracture license services.
So as far as my understanding is, all hospitals who deal with fragility fractures need to have a fracture liaison service. So all hospitals will have a fracture liaison service. Some would be better than others. Some the capture would be less. So that's why the regular audits. But again, all would have compliance or access to DEXA scanning. The DEXA scanning itself may not be there in that hospital, but then they will have arrangements with hospitals which have it, and they can refer them there.
Can I?
Dr. Manish, Dr. Sharad, okay, Amit, yeah.
I was just telling, I heard Dr. Sharad Agrawal ask about the private setup. Can I just add one thing? Initially, I think the Fragility Network, just correct me if I'm wrong, was started as a non-government charitable organization by the patients who were suffering from these fractures. So they made a network, and then they were able to. So I'm sure a charitable organization can always be started in India to at least educate, if not treat, these fractures.
Actually, Dr. Sharad, we have fragility fracture liaison services in AIMS. I think we started it in trauma center, and really it works because you follow up the patient, and for years together, and there is really evidence that it will decrease the secondary fracture. It may decrease, and all the patients are properly followed up, and they are combined lectures, group lectures for them.
Who will bear the cost? In the private sector, the insurance is.
Sir, AIMS के अंदर तो it was part of, like, or Chief Professor Malhotra gave us the staff for that, so it was just easy for us. So, but you are right, in a private practice, it's going to be a difficult task in the beginning maybe.
I think
you just need one person for that. Basically, he or she has to coordinate the things basically. I think treatment and rest of the things, they remain same, but only one person who coordinates what exactly is to be done after the fracture is fixed. I think just follow up and proper movement of that patient in the hospital, proper timeline, proper talking to the patient, nutrition, diet, physio, all that thing. So it becomes quite good for the patient.
It is very good, but it is a lot of hard work. And as Amit says, maybe involving the involuntary or the voluntary sector might be the way to start it. And then the government, when it realizes the benefits, it will always try and help, I think.
Dr. Inder, is there any concept of using hip protectors after a fall? There's something called padded thing on the hip, so that even if the person falls, he doesn't get that fracture.
Yes, so that's the part of the falls risk assessment. So everyone more than 65 years will have a falls risk assessment. They'll see what their gait is, whether they are unsteady in the gait, whether they are getting repeated falls, what's the environment, whether they are living in a carpeted floor or hard floor. So they will look at all of this, and then they'll recommend, if patient is having repeated falls, to put hip protectors. If they are living in places where there's hard floor, maybe putting carpeted floors. And all these measures, they look at even the home environment sometimes to try and suggest improvements. So it's all part of the falls risk assessment.
I ask a small question to Dr. Amit.
Yeah, Samar.
Sir, you said that you try to operate all hip fractures within 48 hours. You try to operate them within 24 hours, but you do not try to cross the 48-hour limit. My question is, even we try to do the same. We even in fact try to do them within the first 6 hours when they come to us, but we have a lot of problem when we have these patients. Many of them come with the history of transient ischemic attacks, if not a CVA. And that is the time when we are unable to convince our anesthetists, because for most cardiac patients, we are able to do that with our anesthetists, but TIAs and CVAs are some things for which it takes a little longer for us to rule out anything, because most of the neurological investigations for clearance for surgery take a longer time for us. Any tips or any protocols that you use in UK to operate these patients within the 48-hour window?
So if they, again, these elderly patients are coming with falls, and one of the important reasons could be they've had a stroke or a cardiovascular event that might have triggered the fall. So yeah, a lot of them do have these problems. So what we do is we get of course, a history ECG, and if there is any doubt about it, troponin is measured. So we do 2 troponins at an interval of 12 hours. And if the troponin is rising, then they go into under the cardiologist, and we try to manage that. Then they don't go into the 48 hours. So
my question is mainly aimed at neurological problems rather than cardiac, sir.
Neurological. So if they have a stroke,
if they have a transient ischemic attack, now they are absolutely normal, but they have had a transient ischemic attack. That is the time when our anesthetists feel a little unsafe to give anesthesia to these patients. We've had a lot of problems with cardiac related problems, but most of the time now, with all the evidence coming in favor of early surgery, even for cardiac patients, our anesthetists are very happy to give us anesthesia for these patients.
Yeah, it is. You have to balance it out. If they're having an acute stroke at the moment, and that is different. For a transient ischemic attacks, most of the time we optimize them, get their fluid volume up and their parameters optimized, and then we take them to theaters. Most of the anesthetists are happy to go ahead. I think they prefer using spinals and regional blocks for them to get the stress level low. But yeah, if you balance it out, it's been shown that if you don't operate, they are probably the worst patients who are going to suffer the most if you don't operate on them. They won't be able to walk, and they would suffer from consequences of being on the bed for long.
Thank you.
Okay, I think Dr. Manish, we have some time, or we are just 55 minutes,
Dr. you're not audible.
I'm audible, sir.
आवाज नहीं आ रही है. आप ईयरफोन रिमूव करके डायरेक्ट बोलिए एक बार.
Hear me now?
Yeah.
Can you hear me?
Yes.
Yeah, now you are audible, sir.
Yeah, I have taken extra time. You can take cases.
Okay, great.
डॉक्टर शरद, अब आ रही है आवाज?
हाँ आ रही, मैं डॉक्टर
ऑडिबल,
आपकी तो आ रही है।
अच्छा, किसी और की नहीं आ रही थी, मुझे लगा मेरी नहीं आ रही, मैं तो अपने ईयरफोन से हटा दी इसलिए।
नहीं, मेरे
मनीष सर की नहीं आ रही थी एक्चुअली।
I was not able to, I was not audible. So, but I have taken extra time. Please take up the cases.
Okay. So, Dr. Kapil is there. मुझे लगा जिन्होंने केस प्रेजेंट करने तो दोनों के दोनों ही।
Okay, then we wrap up. If we can take next time.
Yeah, so I think on behalf of DOA and our organizing chairman, Dr. Malhotra, I would like to thank all the faculty members for sparing their valuable time for this MIDCON. And it was a great academic session. So over to Dr. Hitesh Lal for the vote.
No, first Dr. Sharad, your opening, your closing remarks.
Yes, sir.
Sharad.
Okay, Dr. Manish, my thanks to our chief guests of the evening, Dr. R.C. Meena, President, Indian Orthopedic Association, guest of honor, Dr. Atul Srivasa, Secretary, Indian Orthopedic Association, other dignitaries from IUA for gracing the MIDCON 2020 by their presence. We are grateful to the eminent international and national faculty who spared their valuable time, made lucid presentations, and contributed their thoughts on the subject. Thanks to Dr. Rajesh Malhotra, Dr. Vijay Sharma, and their team, hosts of MIDCON, for organizing this wonderful conference. Sincere thanks to Executive Committee of DOA for all their hard work for the success of the conference. Special thanks to all members of Daily Orthopedic Association and all delegates who joined us today and made the conference successful. Thanks in particular to Dr. Manish Dhawan and Dr. Ravi Chauhan for their untiring effort in organizing these webinars. Thanks to Dr. Shamsul Hoda, Dr. Neeraj Bijlani, and Dr. Ashok Sham for all their technical support. Thank you.
Thank you. Dr. Hitesh, your closing remarks, and you can announce about the part B on the next on next Sunday. Dr. Hitesh, please.
Yeah, thank you. It was a great academic interaction. I am thankful to the IUA icons, Dr. R.C. Meena, Dr. Shivashankar, Dr. Atul, and the august faculty, Dr. Vikas, Dr. Kapil, Dr. Kotwal, Dr. Amit Sharma, Dr. Tahir, Dr. Shivashankar, and Dr. Inder. And I want to just make an announcement that on the behalf of DOA, we will be holding a e-quiz for the first time, which will be camera monitored, and an e-poster competition will be done before the next MIDCON. The next MIDCON is on 19 July, Sunday, and that day also we will be discussing the fragility fractures, the endocrine part, and the orthopedic part. Do join us next time also. Thank you.
Okay, final comments by Professor Mani. Dr. Lalit Mani, are you there? Dr. Lalit.
I'm very well there. Thanks a lot. I think it's been a great session, and I think we'll have an even better session next Sunday with the e-posters and the quiz. Thank you all for participating.
Okay, I thank all faculty.
Thank you, sir.
Thank you very much, and good night.
Sir, can we stop live now?
Yeah, you can.
And Dr. Shamsul?
Yeah. Thank you, sir. I'm stopping right now, sir. Thank you, everybody, sir.
Thank you.
Thank you. Bye-bye.
Thank you from Orthopedic, sir.
Bye.